webinar after. A few practicalities. Please ensure your microphones are muted. As you have noticed, all microphones are by default on mute, but if you want to speak, please remember to indicate so in the chat and mute your microphone after again. If you want to ask the questions, there are different ways to do this. The first option is to do this in the chat. The other is to, and then after one of the moderators, myself or Vivian at Siapia Wama will give you the speaking privileges. And we will be using the program called Mentimeter for in the beginning. So please make sure that you have your phone ready to answer a few questions to get to know each other better. I will skip this for now and instead want to give the floor to Ms. Koiwa. Koiwa, are you available? Oh, I think you need to unmute yourself. I will do it manually. Yes.
Can everyone hear me now?
Yes, we can. The floor is yours.
Okay, good morning, everyone. It's good to meet you all today, online. I never thought our second scientific meeting would be here, but here we are. So today is World Preeclampsia Day, and so we are commemorating the day by having this event online. My purpose here this morning is to tell you why we are gathered here, the purpose of this gathering, basically. And so I'm going to do that by just reading something brief that I put down. And I would want you to pay attention. So, ladies and gentlemen, distinguished speakers, all protocols observed, good morning once again. My task here this morning is to tell you why we are gathered here today on this platform for this meeting. Let me do that by allowing us to relive the experience of a wonderful Ghanaian family. If you are a woman, imagine being young, in your late 20s, exuberant in character, married and living in Ghana. If you're a man, imagine being a young lawyer and a husband to this woman. As a young couple, you were lucky to have conceived the same year you got married, somewhere 2012. Such excitement you exhibited as you started your 9-month journey of the unknown. As a pregnant woman, you diligently attended regular antenatal at a private hospital with your husband. As the months passed, you observed drastic changes taking place in your body. You gained excess weight, but you received praises for it and was told it was a sign you'll be having a baby boy, although the scan said a girl. You sometimes felt unwell and had headaches, but presumed it was normal. When you complained a few times to a nurse during your antenatal visits, you were told you will be fine. Never did you ask any question, but to accept what you were told by your health practitioners because you had confidence in them. 27 weeks down the pregnancy lane, when you finally complained to your husband one day, he told you to rest more, and you did. However, as around 2 a.m. the following morning, as you were resting, you started shaking vigorously, foaming, and gradually becoming unconscious. The last you could hear before you passed out was your name being called, but you could not respond. Between the time of your unconsciousness and consciousness, almost 24 hours thereafter, you woke up to a severe pain, a severe abdominal pain, only to be told that you were rushed to a public hospital and had been delivered through an emergency cesarean because you suffered eclampsia. Never had such a strange name passed through your ears. Where is my baby, you asked? Your baby is fine, and at the neonatal intensive care, you were told. After 3 days, you managed to walk to the NICU to see your premature baby, who turned out to be a boy. So tiny and frail was your less than a 1 kg baby, whom you bonded with over a period of 3 days. Few days after, you were discharged and told to come to regularly check on baby. Sadly, when you visited the following day with your husband, the baby had died due to respiratory failure. And that was the beginning of your long journey with pre-eclampsia, eclampsia, and HELLP syndrome. Fast forward a few years, you and your husband lose additional 2 babies due to pre-eclampsia and HELLP syndrome in 2017 and 2020, respectively, all of which you were delivered surgically. Your last experience was nothing but a life and death situation. Out of 4 pregnancies, you have only 1 surviving child, your miracle baby, your second child, with whom you did 6 months antenatal in Ghana and traveled to the US for further care. Unfortunately, you delivered the bouncy baby girl at 37 weeks, even though you still suffered pre-eclampsia, but at a later onset. Ladies and gentlemen, this is my story. This is my suffering. This has been my faith. And this is the inspiration behind the formation of Action on Preeclampsia Ghana, the organizers of this scientific meeting. My fellow participants, losing 3 babies to preeclampsia, eclampsia, and HELLP syndrome is tragic. As others receive accolades of congratulations, you receive accolades of our condolences. But don't we all deserve the congratulations? As a couple, we've been traumatized physically and emotionally over and over again because of this disease. Not to talk of the huge financial burden associated with it. My life has been at risk because of this disease, and I ask why. Where did we go wrong? Yes, with the first pregnancy, we were ignorant, even as intellectuals, but subsequently, we were not. Such that with the last pregnancy, we did all that we could, from self-monitoring of blood pressure, frequent antenatal visits, healthy diet, exercise, diligent intake of medications, and yet, just 4 weeks ago today, we lost our premature baby girl, Grace, born at 30+ weeks, weighing 0.9 kg. So much tears have I shed as a bereaved mother, so much pain have we bore as bereaved parents, with only 1 child to compensate our pain. So I still ask why. What needs to change? Can we ever defeat this disease? And I say, yes, we can. Fellow doctors, nurses, researchers, policymakers, advocates, and students gathered here today, I share this story not to discourage us, as I almost was. I share this story rather to empower and remind us that there is still more work to be done. I share this story not to downplay our progress as a nation in healthcare, but to let us know that as a scientific community, we have come far, but we still have a very long way to go when it comes to this disease. And this is the reason why we are gathered here today, to share ideas as experts on how to deal with the fatal stings of preeclampsia and its impact on women and families. Under the theme, Preeclampsia Vigilance in Screening, Diagnosis, and Management. As we deliberate today, I leave us with these questions to ponder over. As Ghanaians, as experts, do we have the passion and capacity to deal with this serious pregnancy disease? Do we have the passion and capacity to ensure that no woman dies giving birth? Do we have the passion and capacity to ensure that every baby is given a chance at life? On this note, I entreat us all to enjoy the meeting, engage each other, and come up with an action plan to defeat preeclampsia. Thank you.
Thank you, Koiwa. I'm going to start a short video that was shot in 2018. Let me share my screen again. And it also tells your and your husband's story.
Thank you, Joyce.
According to experts, the health of...
Just a minute.
Women and children has become established as one of the most important indicators for measuring a country's level of development. The World Health Organization, for instance, explains that the well-being of societies is directly linked to the health and survival of mothers and children. When mothers survive and thrive, their children survive and thrive, and societies prosper. For Koiwa, enough is enough. She is unwilling to risk her life again in an attempt to have another child.
Anybody hearing me now with what I'm about to say will say, what kind of a woman is this? But I pray to God, telling him not to give me a baby. I pray. That is the sort of prayer I pray. At times I miss my mess, they're like, oh, the babies. I'm like, is that normal? It's not, because I said I don't want to go back to that operation room. It's a very scary place, between life and death. And if you have to go there twice, like I have, go into so much pain and come back with no baby to compensate your wounds, then I really can't go there. I can't go there again. And so I told my husband, I know I'm still young, there's a potential, but I'm done. I tell the doctors, and they're like, oh, well, now that we know yours is like a hereditary thing and you're like high risk, we can manage you. I'm like, no, I want to be there for the at least one that I have.
And her husband, Dennis Ofuswapia, supports the stance.
In my view, I think it's okay. That is what I keep telling her, because it is life-threatening, and she has gone through this 3 times. Even Dioli, she had it, but it makes us almost draw the same conclusion that because of the system where she found herself, they managed to keep it down for at least 2 weeks before finally they took Dioli out. So she has suffered too much, and I think that you have 1 child. It's okay. Others don't have.
Oh, I'm sorry.
Have 1 child. It's okay. Others don't have, but they are there. So as far as I'm concerned, I think we can live and be okay with ourselves, with our child, and move on in our life.
Nobody jokes.
Okay. I saw in the chat there was one request to post the link to this video, and we'll post it shortly during the presentations. So you can also watch the full Joy TV screening. Thank you again, Koiwa, for sharing your story. And at the beginning of this scientific meeting that brings together many people with very different interests in hypertensive disorders in pregnancy, to the real purpose of why we're doing it are stories like yours. So thank you for sharing. I would like to invite, just a minute, Marcus Green next. APECGH, one of APECGH Ghana's partner organizations is Action on Preeclampsia UK. Marcus, can I invite you to share your thoughts?
Good morning, and a very huge thank you for inviting APECGH in the UK to join you today. It's the most enormous privilege to be a part of your conference and a part of your meeting, and to hear what Koiwa had to say. It just puts everything into perspective, doesn't it? That we are patient-led organisations. We're here to work on behalf of patients, and we're here to make sure that the very real stories that we hear day in, day out become rarer and rarer as we work to deal with preeclampsia. Koiwa has been an absolute inspiration, as have the team that have set up APECGH Ghana in the last few years, and it's a great privilege and a great honour to work alongside you. And thank you very much, as I say, for inviting us to be here today. We live in very interesting times with COVID-19, and it's quite clear that it would have been very difficult for APECGH to physically come and see you for this meeting. So the fact that we're all online brings the worlds a little closer together and makes everything a little bit smaller, and it's a great pleasure to be here. And what I certainly couldn't have done was bring members of my team along to the meeting in Ghana. So I'm very pleased that both Rowan Wiseman and Rowan Grigg and Charlie Gledhill, who are both members of the APECGH UK team, are listening in on this meeting and looking forward to hearing what's discussed. And also Professor Andrew Shennan, who's my chair of trustees, will be joining in later. So thank you very much for that. I think that there's much that APECGH in the UK can gain from working closely with APECGH in Ghana. We bring different perspectives to the same problem, and the more that we do to work together, the better. And on this World Preeclampsia Day, it's lovely for us to be able to share some of what we're doing in the UK. And I particularly want to mention the launch of our YouTube channel today. We've just launched that, and we've got about 12 videos on there, including some from the Happy Project, which is really important to us. And we're very, very pleased that that's been launched today. And if you go to apec.org.uk, you'll see a complete page of new resources that we've developed, including a new Instagram page as well, launched this week. Now, finally, what I would like to say is one thing that we've worked on very hard in the last couple of years is our training for healthcare professionals on preeclampsia. And I'm very pleased to say that this now has continuing professional development accreditation. So that has been launched today. You can get details of it on the website, and it's completely free of charge. So any midwife who would benefit from signing up to that, please do so. Please use those resources, and please work with us so that whatever you need from us and however we can work more closely together, we'd very much like to do that. I'm aware that time is running away, so I will leave it there. But Dr. Brown, thank you very much for having me. I greatly appreciate being here.
Thank you. Are there any questions so far? For either Marcus Green or Korwa? If so, please.
No questions. No questions, Joyce. You're fine.
Okay. As I mentioned, we are with a very diverse group of people. So what we would like to do is get to know you better for those who are joining us. I'm going to share my screen again. And what I would like you to do is go to the website www.menti.com. And you can do so either through your web browser or your phone, and use the code 259667 to answer a few questions so we know who's here. So the website is www.menti.com, and the code is 259667. If you cannot join because you are using your phone to dial in, just answer these questions in the chat. So we want to get an idea of who's here. I see two people found their way from the Netherlands, someone else from the Netherlands. As you can tell, we are using this often also in our education. So the Dutch people here have a slight advantage. Someone is joining from Burundi, and I think I know who that was. Welcome, Tarek Nagit, an obstetrician gynecologist in Burundi at the moment. I see in the chat some people also start responding. London, Hazel Fofi.
That's great.
Someone is in Georgia at the moment.
Yes.
In the UK, in England, from Ghana, in Germany, in Accra,
Great.
Edinburgh. Many people say Ghana. Are you all based in Greater Accra region or other cities in Ghana too? in Takoradi, Accra, Austria. And it's one of the beauties of, or one of the advantages of our new online world and reality is that it is easier to connect across countries without having to travel. I see someone joined, or two people joined from Kumasi, Isaac Boateng and Mohammed Ainoson. Someone from Abuja, Alexander Dachun. Someone from Accra, from Wa in the Upper West region in Ghana. Worcestershire in England. It's nice to see who we have joined, and there will be a recording of this meeting, so also after many more people in the world will hopefully see this. I'm going to move on to the next question. And that's a question about who you are as an audience. So what drives your interest in hypertensive disorders of pregnancy? Are you a health professional, a policymaker, a researcher, a survivor or current patient, a family member, a student of medicine, midwifery, nursing, or other? And if Mentimeter doesn't work, please indicate it in the chat too. We're very curious to hear who we have in our audience. We also realize some of you may actually have more than one professions or reasons to be here. So one of the inspiring things about Action on Preeclampsia Ghana is that many, well, all its members are preeclampsia survivors, but many are also professionally interested as a researcher or health professional in the topic. In the chat, I see a few answers. Agnes Asante, welcome. You're a midwife, a fourth-year medical student. Fatima Adaham, another midwife, Janet Ajamang, a clinical pharmacologist, researchers, and medical students. You're combining three hats. A midwife, final year medical student. And in the Mentimeter overview, you see the distribution. So close to 40% who answered this out of the 32 is a health professional. We have about a third who join us who are researchers, probably from many different disciplines. I saw in the list an anthropologist. My background is clinical epidemiology and medicine. There are a number of clinician researchers I know. I see Ernest Obeng is a physician and health and safety specialist. So we have a very diverse group here. And to all the students, also very welcome to you. We're very happy that in the early stage of your professional career, you already encounter and learn about preeclampsia, as it is one of the main causes of maternal morbidity and mortality. It's important to join. One technical notice, I see Hazel asked the question if there is a maximum amount of participants who can join. That was the setting before, and it's just changed. Now everyone is able to join with a maximum of 500 people. Okay, let's move on to the next question. Because in addition to understanding better who's here, we are also very interested in what is your main interest. Just a minute, so that's the next question. So what is your main interest in hypertensive disorders of pregnancy? And that could be a certain topic or a certain aspect of hypertensive disorders. And again, you can answer it through Mentimeter or you can answer it in the chat. And we have a very rich program this morning of a wide range of topics. And this will also help us to identify topics for future webinars. Koiwa, I'm not sure if you can read the chat, but one interest is being a motivational speaker. And Kingsley is was inspired by your story. Maybe it's nice for you to link up also after this webinar. And I see very many topics listed. So it's prevention, epidemiology, HELP syndrome as a specific subset or one of these disorders, part of the hypertensive disorder spectrum, supporting patient organization, treatment, prevention, clinical features, management protocol, sociocultural aspects of quality care, pregnancy loss and provider-client interaction, prevention, pre-service education. So this probably also means in midwifery colleges and medical schools to help reduce maternal mortality and early neonatal morbidity and mortality, prediction, epidemiology, improving our understanding. So the pathophysiology. And in the chat, we also see a number of comments. We also see many different organizations are represented. And one of the things that we would like to encourage everyone is to also reach out to each other also after, either through the chat or after this meeting, or through the website or Facebook page of APECGH Ghana, and find each other. So many topics. Thank you for answering. Okay.
It looks like some people have their hands raised.
Oh, I'm sorry.
Chat section.
Yeah, I am going to end my screen because I'm sharing my screen. I couldn't see. Yes, I think a few people want to elaborate. So Gifty, can I invite you to contribute? Gifty, your microphone is on right now.
I'm not sure if you can hear us.
I'm not sure if you can hear. Okay. Later, if you would like, so the raise hand option you can use. And usually the moderators interpret this as, that you would like to contribute. Gifty, I see your video. Would you like to say something? We can't hear you. I see you're speaking, but I can't hear you at the moment.
She needs to unmute her
Well, maybe your microphone is not linked to the computer or Zoom just yet.
Why don't we move on when she figures out?
Okay, let's move on because I would like to invite my fellow moderator, Vivian Etsiap-Boama, to introduce the next section of the program. Vivian, can you join us with your microphone on?
Okay. Hello, everyone. Good morning, and welcome to today's session. Moving on, I would like to invite Dr. Dorothea Obui to introduce our speakers for the next session. Dorothea?
Hello, can you hear me?
Yes.
Okay. Good morning, everyone. It's very interesting to see the diverse individuals that we have around here. And it's a very great privilege to have a scientific meeting once again. And this time it's virtual, very interesting. So our theme for this year's scientific meeting is pre-eclampsia, vigilance and screening, diagnosis and management. And we're going to have very interesting sections with various speakers. And I'm very privileged to introduce them to you. So all together, and we'll know what they have to tell us, various experts. And the very first on my list, I have Professor Kitty Bloemenkamp. She's a maternal fetal medicine specialist and a chair for the Birth Center, Wilhelmina Children University Medical Center, Utrecht, all the way from Netherlands. She has a vast research experience in global health epidemiology. And today she's going to share that experience with us. So she's going to give us an update of the global perspective of pre-eclampsia. The next will be Dr. Emmanuel Srofenyoh. He is a consultant obstetrician gynecologist and a fellow of the West African College of Surgeons. He is presently the medical director of the Greater Accra Regional Hospital here in Ghana. And he's going to give us an update of the pre-eclampsia situation in Ghana. Next, we have Enoch Odame Anto, a PhD candidate from the Medical and Health Sciences Edith Cowan University, all the way from Australia. And he will share with us what he's been doing. He's going to give us something on algorithms. And it's not just algorithms of pre-eclampsia, a novel algorithm. So let's stay tuned. And we have Dr. Salisu Ishaku. He's a director of Population Council's Reproductive Health Program in Nigeria. He provides specialist advice for reproductive health policies to the Nigerian government. And he's going to tell us something about how to prevent pre-eclampsia in terms of the morbidity and then the mortality. We also have Salim Wangabi. He's a clinical psychologist and at the Greater Accra Regional Hospital. He works with the Severe Pre-eclampsia Outcome Trial Study, popularly known as a SPORT study. And he's going to give us some mental health perspective on how women with pre-eclampsia the mental health of pre-eclampsia the mental health of women with pre-eclampsia. So these are the breakdown of the presentations that we are going to have today and the presenters as well. And I think this is just an A to Z of what pre-eclampsia really is. And at the end of all these presentations, I'm sure that we are going to be very up to date of where we are with pre-eclampsia and then where we are going. So I urge you all to get all your questions ready as we listen to our various presenters. And then Vivian and Joyce will carry on from there. Thank you very much.
Thank you for this introduction of speakers. I would like to give the floor to Professor Kitty Bloemenkamp. I'm sharing my screen right now. Kitty, if you would like me to go to the next slide, just say next slide and I will press enter.
Yeah, thank you very much, Joyce, and thank you very much the organizing committee. It's really a privilege to join this meeting, and we are all in a difficult time, but I think there are also some advantages, and as Joyce already said, there's so many people now in this meeting, and I see some old friends. The only drawback from all this is that I can't join you really live, and hopefully that will be the case next year. I would love to tell something about the epidemiology of pre-eclampsia. Next slide, please. And that from the perspective of the INOSS, which is the International Obstetric Surveillance System, which is a network organization. And I will tell about that a little bit later. We just heard a very impressive story of a survival of pre-eclampsia, but we have to realize that still every day more than 800 women are dying because of childbirth, pregnancy and postpartum. Next one, please. It's not only the mothers, and as we heard from the patient story as well, it are the neonates. They are born too early, too small, and there are many stillbirths. Next one. The good news is that the maternal mortality rate is coming down. And you see it's in some areas in the world globally, it's going faster than others. And for instance, in the high income countries, it's sometimes so low that you wonder if it's possible to bring it down even further. But as you could see as well in the beginning of the global chart, there's a huge difference in it. Next one. This is Ghana, where you can see it comes down. I wonder if Ghana has the very recent figures, but otherwise I could do a suggestion. That's an easy way to collect them is through one of the obstetric surveillance systems, which will be part of my talk. Next one, Joyce. What we know as well is that even if it's low, the maternal mortality rate, it can go up, as was shown recently in the USA, in the States. Next one. Where you can see it's really coming up, and there are many different causes of this. It's not completely clear. You think, is it the case mix? Are the women, are they more at risk to die from childbirth, or is it the access to care, or is it in the providers? Next one. What are the causes of maternal death? Next one. There are many different causes, and I mentioned already some. Are there people around who can help out with the birth or with the pregnancy, the monitoring of the pregnancy and postpartum? Is there access to care? What is the health state of the population itself? But a lot has to do also with the empowerment, I would say, of women. And then a big issue is the fertility and family planning. And then we have the underlying diseases, and I will go a little bit more into this detail in relation to preeclampsia. Next. When you look at the whole picture of where women are dying from, 28% globally is dying because of pre-existent medical conditions exaggerated by pregnancy. And that could be diabetes, malaria, HIV, obesity. And you can see that 14% is caused by pregnancy-induced high blood pressure. Next. When you look globally, you see differences. Still, number one, the cause of maternal death is postpartum hemorrhage. And that's a quality of care, access to care, but also availability of blood products. But as you can see, it's also a difference in the prevalence of pre-eclampsia and hypertensive disorders, which is in Africa around 10% of the causes of maternal death. And it's much higher in Latin America and the Caribbean, where it's up till 26. Next. When you go to the high income countries, you see from the causes of maternal death, it's in the top 3 is hypertensive diseases and preeclampsia. So worldwide, I would conclude it's a huge problem, preeclampsia. But maternal mortality is only the tip of the iceberg. We have severe morbidity, and one of them is eclampsia or liver rupture or cerebral bleedings. Then you have the morbidity itself, and then you have the uncomplicated pregnancies. Next. The International Network of Obstetric Survey Systems is a network, voluntary, I have to say, in which countries are working together, and they are trying to collect in the same way population-based data on different subjects on maternal mortality and morbidity. Next. Here you can see different countries. It's like the UCOS, they started actually. So in the UK, it's in Italy, it's in the States. They are in some states, members are starting with it on the population-based collection. Germany, they just started. It's Belgium, Australia, France, Suriname. Now we have new members, which are South Africa and hopefully Ghana soon. Next one. Here you see again around the world, globally. Next. How is it done? It's done in different ways in countries, but from the Netherlands, the Netherlands Obstetric Surveillance System, we did ask all the hospitals with maternity units to have one person who does collect all the data. And we send out very simple, just one email every month to ask them if they have cases of either maternal mortality, and for instance, eclampsia, severe postpartum hemorrhage, or like now, COVID positive women. And in that way, we get back the case, and then we can ask for the whole case file. And then next one. We do in all those countries from the INOSS, we use the same definitions and methodology. And then a good thing about it, I think, is that you can see if there are differences between countries, but you can also compare management strategies. And I think that are the lessons to be learned from this whole network. The other robust thing is that we use population data. As I said, the lessons learned, and you can make recommendations for that, and then you can implement this in a plan, do, act cycle. Next. In the Netherlands, we learned in, say, around 2006, and we did the Lemon study, which was a prospective nationwide collection of all eclampsia data, that we had a much higher incidence than other countries, which were all high-income countries. And then we were thinking, what's happening? Is this because we use different definitions of eclampsia? Are there different patient characteristics? Or is the management different? In all the cases, we could see that about in 85% of all the cases, there was substandard care. Then we compared, next, within the INOSS setting, we compared our data with the UCOS, with the UK data. And we found out they did use another definition. But at the end, when we combined it in the same way, using the same definition of eclampsia, next one, we could see that there was a little bit difference in case mix. So in the Netherlands, we had more women who have multiple pregnancies, so twin pregnancies, and they had a higher maternal age. But there was also a difference in management. In the Netherlands, less antihypertensive drugs were used when the women came in with eclampsia, and also there was less magnesium sulfate used. And the other thing is, after an eclampsia, in the Netherlands, we would wait longer before women to deliver. So from this way, we learned we have to change something. And we implemented this, all those lessons, into our guidelines. And then we used the NETOS network again to do a new registration, now in 2013 till 2016. And then we could show that 60%, there was a 60% decrease of eclampsia incidence. So I think that's also a good thing of all those registration systems, that you can also show that you are really doing the good job and that you are showing that your incidence is coming down. The other ones are the ones from amniotic fluid embolism and cardiac arrest. And then you can go into detail. What are the characteristics? What's the management? What can we learn from this? Next. From the very recent data in the Netherlands, we could learn also that at the moment we do use actually a high rate, we do have a high rate of magnesium sulfate for prevention of eclampsia. But we also, what we do see is that the monitoring after women is coming in with the eclampsia, the monitoring is there, but the action taken to decrease the blood pressure is not fast enough. And I think that's one of the lessons, to bring it even further more down, that you really need a system where you act really more quickly on when you find a high blood pressure and you start antihypertensive medication. The INOSS itself, as I said, had problems because when you want to compare data globally between countries or regions, you need to have the same definitions. That's why we did perform as an INOSS Delphi, where we had at the end, after several rounds, we had an accepted definition by the whole group. And that's how we now, when we start a collection again of eclampsia, we would use this definition. I think those obstetric surveillance systems are also very helpful in rare diseases, or if something is emerging, like we have now the COVID, the corona crisis pandemic, where we could do now in 70 countries in 1 month, we did start up in 17 countries within the INOSS network. We did start collecting all data on women who are COVID positive. And the good thing is that I can show you already, next, Joyce, already now for the Netherlands on the left side, the numbers, how many women are infected with COVID positive, who are COVID positive. You can see it on the left one, and you see it's more in the west of the Netherlands than in the middle. But also from the UCOS data, you can already see that what are risk factors for women to have COVID positive, who are more vulnerable. And that it's, again, maternal age, it's obesity, and it's Black women, and it are the ones with underlying diseases such as hypertension. These data are just now. And I think in this way, and that's how I want to conclude, these surveillance systems, which are really, I have to say, rather easy to install, and it depends a little bit on your regulations about privacy. We do it by a mailing system, but you have also countries where they even do it by WhatsApp. Like in Suriname, they had a system where they even could send, say, we have a case of eclampsia. I'm not saying that WhatsApp is safe regarding the privacy, but when the regulation is not that strict, that could be an option as well. But I think in that way, you can register the maternal deaths, the near-miss maternal morbidity cases, but also the perinatal mortality and morbidity. And in that way, in several countries, there's an audit installed where you can go next to the comparison within the country with other countries, go into more detail and audit, but you need a no blame, no shame culture for that. And you have to do that with more people. You can do the data analysis. You can say, these are the good practices. Here can we learn something from it. From the lessons learned, you can go up till the guidelines and implement it in the new guidelines or make guidelines when they are not there. You can have research adhere to it, and then you can go further around the cycle. And I think this is how you can improve maternal and neonatal health. So in summary, next, I think eclampsia cases may be accurately defined using clearly defined clinical criteria. And I think INOSS did make an attempt to make a good definition for that. When you use the uniform case definition, you can easily compare between countries and between regions. Preeclampsia management does differ across the world, and I think the network can help to collect additional clinical information also on rare diseases or pandemics, and can inform to make a better future management. Next. In conclusion, it's a pity that I can't go now to Ghana, but I'm sure we will meet again like we met last November in 2019. And here you see many of my colleagues and friends in Ghana. And again, thank you so much for the invitation. And this is a picture of the whole NETOS and INOSS team.
Thank you, Kitty. We will, there will be an opportunity to ask questions after the next speaker, and I would like to invite Dr. Srofenyoh to the floor. Dr. Srofenyoh, can you share your screen? In the top, in the bottom, you see the green icon in the middle with share screen, and if you then select your PowerPoint, you should be taking over, and we should be able to watch your screen. Yes, we can see it. If you press full screen, then we can. Yeah, thank you. The floor is yours. Sorry, Emmanuel, you're still on mute. Let me see if I can unmute you. Okay. Yes, now your audio is on again.
Yes, so thank you very much, Joyce, and all the other organizers behind the scene who have made this community, this gathering, virtual gathering possible. And the topic of my discussion this morning is pre-eclampsia, the Ghanaian situation. I'll be brief, and then I'll leave space for questions. This is going to be the outline of my presentation. I'll talk a little bit about the prevalence in Ghana, the changing impact of pre-eclampsia in Ghana, perinatal outcomes and case, and I'll do one case presentation before I conclude. So by way of introduction, as had been said earlier on, pre-eclampsia and other hypertensive disorders of pregnancy have become a major cause of maternal mortality in Ghana, especially in the major institutions of care, be it Accra and the other cities across the country. It has become a major cause of maternal mortality. And indeed, it is one of the reasons why Ghana failed to achieve her SDG targets, SDG 4 and 5 targets. Hypertensive disorders are also important cause of maternal morbidities, and the chart has been shown earlier on. Sometimes we have patients who end up with acute renal failure and progress to chronic renal failure, cardiomyopathies, and other complications. It also accounts for significant measure of perinatal morbidity and mortality. If you go to our NICU, neonatal intensive care unit, we have so many babies delivered prematurely who are there, and majority of them succumb as a result of this condition. It also contributes significantly to hospital admission. There are times that when you go to our wards, the entire ward is full with women who have pre-eclampsia, who are admitted to the ward awaiting pregnancy prolongation a little bit before they are eventually delivered. So this is how serious the condition we have on hand is. Now you see the graph. This is the graph that shows how Ghana has fared over the years as far as maternal mortality is concerned. You see that initially, in the initial years, we've made significant progress, but from 2010 onwards, progress has become we've not been making much progress. You see that our graph has virtually flattened. And several analyses have shown the lack of progress in survival from pre-eclampsia is one of the reasons why we are not making much progress. Because we've made significant progress when it comes to hemorrhage and its management, when it comes to unsafe abortions and their management, and so on and so forth. But when it comes to pre-eclampsia, progress has not been as much as we would all like to have it. So I'll talk a little bit about prevalence in Ghana. It is so difficult to get the accurate prevalence in Ghana. The true burden of hypertensive disorders in pregnancy is been difficult to determine. Worldwide, we know it's estimated to be around 10%. But in Ghana, there have been a few studies, which I'll make reference to. Is usually put between 6.55 to 7%, Ahenkura et al., 2009, and Professor Obed et al., 2006. However, in 2015, Joyce Brown, who is incidentally is also a member of this panel, carried out a cohort study where the prevalence of pre-eclampsia in Ghana was put to 7.5%. The prevalence in major referral institutions like Kolebu Teaching Hospital, the Greater Accra Regional Hospital, RAGE, and the other bigger hospitals where the cases are referred to are obviously higher. And one study at Kolebu Teaching Hospital put the prevalence at that hospital to 21.4%, which is very high. This is a chart that shows the prevalence rate in the Greater Accra Regional Hospital, the hospital where I work. And you can see that over the years, the prevalence has been relatively high. It's ranged between 15.5% Yeah, and then most recent year, 2019, the prevalence has jumped to 22.2%. And this is very high. It is partially because of our referral nature, but it also reflects the numbers that are coming, the numbers that are being discovered every now and then at the various district hospitals before they are referred to us. I also have a chart there showing case fatality. And as you can see, case fatality for preeclampsia in our mothers, in the women who develop preeclampsia, ranges between 1.2%. Sometimes we do well and it's around 0.5. Averagely, I'll put it at around 1% case fatality rate. And the implication of this information is that when you have, for every 100 women who have preeclampsia, it means that in Ghana, for every 100 women who have preeclampsia, probably one of them will lose their life. Or when you have within our institution, for every 100 women who comes with preeclampsia, one loses her life. That is the practicality of the information that I have projected. There is also another thing that we have discovered recently, that there is a changing pattern of preeclampsia death in Ghana. There has been a changing pattern. So please pay particular attention to this chart. In 1963, one of our senior consultant professor, in his data collection, showed that hemorrhage contributed 65% of maternal mortality in those times, and preeclampsia contributed only 15.4% in 1963 to 1967 data, as you can see. But the story has changed over the years. Between the 1980s to 1994, that 10-year period, preeclampsia and hemorrhage were virtually neck to neck. But from the 2000s, you can see preeclampsia or hypertensive disorders overtaking hemorrhage as a leading cause in the facility in which this data was collected, and that was Korle Teaching Hospital. And then in the 2010 and further advances took place, and then you see more and more cases of women dying from preeclampsia rather than from hemorrhage. So this is the situation that we have in most of the major institutions. So Korle Teaching Hospital, the Greater Accra Regional Hospital, and then Komfo Teaching Hospital, all the bigger institutions that receive more of the cases. This is the story that we are seeing now. It is no longer hemorrhage as a leading cause, but it is preeclampsia in these facilities. This is data that we also collected in the year 2016. And as you can see from this data, we collated preeclampsia death across the entire city. We are no longer talking about what is happening in the bigger institutions alone, but what is happening in all the institutions in the city. And we realize that as far as the entire region, let's say Greater Accra region is concerned, hemorrhage contributed 63 women died from hemorrhage, and as many as 60 women died from preeclampsia. And so this shows clearly that even at the regional level, when we look at the entire region, and for many other regions, preeclampsia and hemorrhage are becoming neck to neck. So apart from the fact that in the bigger institutions, preeclampsia is becoming the leading cause of death, even when we take all the institutions together, preeclampsia is still a significant contributor to maternal mortality in Ghana. Again, this is data that we collected over a 5-year period from 2015 to 2019. And again, over this 5-year period, as you can see, obstetric hemorrhage contributed 48 cases, 33.3%, hypertensive disorders or preeclampsia. This is 7 women over this 5-year period passed away, losing their life, and that contributed 46.5%. And you can see the rest as it unfolds. So this is the situation. Hypertensive disorders, preeclampsia is now a leading cause of maternal mortality, even in the Greater Accra Regional Hospital. And so we did further analysis in Ghana here to appreciate what the underlying factors that are responsible for mortality. After postmortem is done and after audit, we come to some conclusions. And this is how it panned out. cerebrovascular accident contributed 31.3%. Fluid overload, which is mainly iatrogenic as a result of management. Maybe we administered excess amount of fluid because preeclampsias don't tolerate fluid. That contributed 31.3%. Multi-organ failure like kidney failure and all other organ failure contributed 18.8%. And renal failure alone, when we analyze those patients who have renal failure, contributed 12.4%. So these are the underlying factors why women lose their lives as a result of preeclampsia. So it's going to become necessary in the future to see how we can prevent or minimize these complications in our women. Which management protocols do we use so that we avoid fluid overload in such women? And how can we make sure that we minimize issues of multi-organ failure and acute renal failure? This information, the information on this slide, will serve as an important source of further studies for researchers who are on this platform. Quality of care. Quality of care of preeclampsia women is another important area to look at. Normally, with our current dispensation, the protocol that we use depends on early detection. So we have programs in place to make sure that women who develop preeclampsia are detected early detection, control of blood pressure, and prevention of fit using magnesium sulfate. Magnesium sulfate is widely used in Ghana. And then lastly, timely delivery. Now, apart from fatality rates, which are projected earlier on, eclampsia index can be used to monitor effectiveness and the quality of care to these women. To the extent that if we are getting more and more eclampsias, then we know that yes, we are not managing them well enough. We don't have to wait for death. We don't only have to use mortality as an index. We at the Greater Accra Regional Hospital here have decided to use eclampsia index to determine how well how well patients are being managed. So this actually reflects women who are managed from the sub-district level to the district level before they get to the referral institutions. So because that is where they are detected from, that is where the initial management has started, and that is where they are supposed to even commence magnesium sulfate before they are eventually referred to the higher centers. So the more eclampsias that we get, the more we can assume that care in the periphery and also in the central institutions are not good enough. However, as you can see over the years, from 2015 to date, 2019, we can say that pre-eclampsia rate, the eclampsia rate or the eclampsia index is reducing a bit. It was as high as 7.9 to 8% initially in the earlier years, but last year the eclampsia index in Accra Regional Hospital was 5.8%, and that was 2018. In 2019, it has improved a little to 5.6%. But again, a whopping 5.6% of the women developing eclampsia is high, and we are hoping to have a situation in the near future where virtually none of them will develop eclampsia, that will be able to manage them early enough so that they don't even develop eclampsia. The reason why we chose eclampsia as an index is that we know that once the woman develops eclampsia, the woes of the woman will become higher. The risk of death is higher. The risk of having multi-organ failure is higher. The risk of all the other complications, intracerebral bleed, is higher, and so on and so forth. So if we can identify this as a complication that we can reduce, then we will be on the right path to reduce the other complications. So talking about perinatal outcomes, again, there have been relatively few studies in Ghana which really focus on perinatal outcomes. I will talk about a few of them. There was a study conducted in the Ridge Hospital, published in 2015 by Joyce Brown et al. And that study showed that women with chronic hypertension have a higher risk of preterm delivery, with an average relative risk of 4.3%, 95% confidence interval being 1.3 to 4 to 38. And then women with pre-eclampsia, women in that study, it was found out that women with pre-eclampsia have even a higher risk for low birth weight, with an average relative risk of 7.95%, and then a higher risk of neonatal death, with an average relative risk of 18.1%. So this is the situation. Even if the woman traverses to term, there is still a risk to the baby. This is another study that was conducted in Kolebu Teaching Hospital, looking at the outcomes of hypertensive women with hypertensive disorders who have progressed to gestation of 37.4 weeks. And this was published in 2017 by Bonsafo and his team. I'm sure Bonsafo is on this, is in this meeting. And in that study, they found out that 24.7% were admitted who had problems, significant problems, for which they needed to be admitted to neonatal intensive care unit. 15.2% had neonatal respiratory distress syndrome, even though the pregnancy has advanced to as high as 37.4 weeks. 3.8% required ventilatory support. Stillbirth rate was 6.8%. Early neonatal death rate was 3.8%. Severe intrauterine growth restriction, 6.1%. Low birth weight was 24.7%. But above all, when we summarize everything, perinatal mortality rate was 10.8%, which means that for every 100 women who are delivered, 10 of them, 10.6%, 10 of them will lose their baby. That is even when the pregnancy is carried to term to 37 completed weeks, still 10 of them, for every 100 women delivered, 10 of them loses their baby. And so this again, we should portray to you what would rather be the situation even when the pregnancy did not move to term. It will even be worse in our circumstances. Before I bring my presentation to a close, I would like to make this short case presentation to illustrate the socio-economic and emotional impact of pre-eclampsia places on our women and their families, and also to illustrate the fact that we still don't fully understand this disease condition. I'm talking about Madam A.A., who is currently 35 years old and has been married for 10 years. She has had about 11 pregnancies in the past, and I've lost all of them through pre-eclampsia between gestational ages of 24 weeks and 28 weeks. So hence, we can describe as an early onset type. Of the 11 pre-eclampsia episodes, this woman had eclampsia 6 times. And indeed, when I saw her antenatal book and I saw the number of eclampsias this woman has had over the years, I was so much alarmed. Now, in the last eclampsia that she had, she ended up in an intensive care unit where she has to battle for her life. After a long battle, she survived. The index pregnancy for which she was referred to the Greater Accra Regional Hospital, she was referred to us at 12-week pregnancy. She was already 12 weeks when she was referred to us. And by the time she came to us, she already hypertensive. She had developed chronic hypertension. Her BP then was 180/120 already at the gestational age of 12. We managed to control the blood pressure to allow the pregnancy to progress. She was on all the medications that we can think about, all the possible medications, antihypertensives. She was on soluble aspirin. She was on calcium. She was on folic acid. She was on multivitamins that contain vitamin B12. Everything that we can think about, this woman was taking the medication. However, by 24 weeks, she experienced an intrauterine fetal death and lost the baby. After induction and delivery, and after she's been discharged, this woman called me and asked me a question, "Doctor, so what should I do again? What should I do again? I've done everything. I've been referred here. You've given me all the drugs that you can give me, but what should I do again?" And I can tell you, I'm still reading and looking for the answers. I couldn't answer it. I'm still reading and looking for the answers. So the question what I want to say now is that what are we doing as a country, because I'm to talk about pre-eclampsia, the situation in Ghana. There are a number of interventions that we are putting in place in Ghana. The first one is pregnancy school. And in Ghana here, we are implementing pregnancy school, both institutionally and then also within the communities. So therefore, it is not only in the hospitals that we organize pregnancy schools. Sometimes of the day, within the hospitals, when they come for antenatal care, there are midwives who have been trained, who will give lectures on various important topics, how to detect, how to monitor yourself for development of these complications and so on and so forth. But we have also decided to take pregnancy school right into the communities so that husbands, grandmothers, and other members of the family will also understand and support the women within their communities who may be pregnant. We've also designed pre-referral management protocols because we want to be sure that once the woman presents to the nearby district hospital or the sub-district hospital, the right things are done before they are even referred, because time is of the essence in those circumstances. So we have designed pre-referral management protocols. So they have to know which blood pressure, at which blood pressures should they give magnesium sulfate, which antihypertensive to use by the midwife, and what they should do before the patient is referred. So that is currently under implementation. Social actions are also important. So actions like APECGH Ghana, what APECGH Ghana is doing is in the right direction and is really supporting the Ministry of Health and also the Ghana Health Service and the obstetricians to help bring education and information to the public. Improve clinical management protocols is another intervention that we are putting in place, making sure that even within the bigger hospitals, we have the right protocols in place to manage the women so that we can improve the outcomes. And that is also in place. Above all this, one important thing that we have also engaged in is research into pre-eclampsia. There are currently a number of research that are going on at the Greater Accra Regional Hospital together with other clusters of hospitals. We have the sport validation study going on. We have the sport bio study going on. And then several other sport-related studies that are being conceived that are currently going on, just to understand how best to manage, especially women who present with early onset type of pre-eclampsia, how best we can manage them to delay the pregnancy a little, or which are the ones that we should just deliver immediately. Also to understand whether there are any genetic factors that are responsible for pre-eclampsia, and so on and so forth. So by way of conclusion, I want to state that the burden of pre-eclampsia in Ghana is huge. It has become a leading cause of death, or leading cause of maternal mortality in most big hospitals. Nationally, its contribution to maternal mortality and morbidity is increasing. It also contributes significantly to perinatal mortality and morbidity. It imposes, and this is what sometimes we don't pay attention to, it imposes a huge social and economic cost on the family. And above all, we still don't understand the full ramification of this condition in Ghana. There is therefore the need for all of us to focus research to understand the underlying mechanisms, to allow prevention and effective treatment and also management of the condition. This is an urgent call in order to prevent needless death and to bring smiles back on the faces of thousands of women and their families who are suffering from the impact of this condition. Thank you so much for listening to me.
Thank you, Dr. Srofenyoh, and thank you, Prof. Bloemenkamp too. I am ending the shared screen option because we've reached our Q&A part. There are in the chat a number of questions have been asked already. I would like to give Isaac Ampoma first the floor to ask his question. Isaac, you should be able to unmute yourself and ask your question.
All right, thank you very much. That's a very wonderful presentation. Thank you, Doctor. Doctor, I work for Ghana Coalition of NGOs in Health, and also I'm in Ghana working for Concerned Health Education Project. You know, Coalition is the umbrella body of all civil societies in Ghana. Doctor, is it possible that we can get multiple infections, pre-eclampsia and also hemorrhage? Again, also in the area of the pregnancy school, in the communities, how do we sustain that? Some of our findings have realized that the pregnancy schools are not being sustainable. And of course, all these cases will end up at the hospital sessions. And then finally, also, with high blood pressure in pregnancy, is it as a result of lifestyle or it is as a result of poverty? Thank you so much.
There are a few questions. Dr. Srofenyoh, do you want to start? And Prof. Bloemenkamp, do you want to add?
Yes, so please let's have the questions in crops. Can you hear me?
Yes, we can.
Yeah, so we have the questions in crops. So if there are other few questions, we can add it before.
Because of time, please answer this one, and then we can see how much time we have to also come to the other one. So please answer this one first.
Yes, so thank you so much. I hope I can be heard. Yes, thank you so much for the questions. First of all, interestingly, these two leading causes of death, there is an important linkage between preeclampsia and hemorrhage. And that is complicated preeclampsia sometimes develop when the woman has severe preeclampsia. There is a complication which can lead to excessive bleeding. We call that disseminated intravascular coagulopathy, or DIC for short. That is a complication which is also very common. And when the woman has that complication, there is a very high risk of bleeding excessively to death. And indeed, some of the deaths that we have had in preeclampsia are because they develop these bleeding complications and therefore lost their life. The other question, so therefore there is an important linkage between these two leading causes of death. The other question has to do with pregnancy school sustainable. We wish we could sustain this because it is an important opportunity for us to deliver life-saving knowledge to the population, both the pregnant women and even the community members. So we wish that we can come together with all the other NGOs and work together and make sure that these pregnancy schools are sustainable, because that is the only way, because some of our mothers will not be able to go online as we have in the developed countries where a woman can go online and read everything about the problem that he may be suffering from. That may not be the case in Ghana. And so it is important that we present this as a way of giving information, the much needed information to women within the communities. The reason why the community pregnancy schools is particularly important is that both women who are not yet pregnant or women who are pregnant and their family members, their husband, will benefit from the information that are delivered there. So let's take it up. Thank you so much.
Thank you. I would like to invite Rosalind Kudo to ask a question. Rosalind, you should have been unmuted now. Yeah.
Hi, good morning.
Good morning.
Please, my question to doctor is, for this situation to go down, what training is there for the health workers to equip them to manage cases on pre-eclampsia? On pre-eclampsia, the training. What training is being provided for the health workers? That is all what I want to find out from them, from doctor. Thank you.
Thank you. Thank you very much. I hope you are hearing me. Hello? Okay. So what training is available for the health workers? So the first thing, as I said earlier on, is that we are developing advanced and improved management protocols. First of all, the pre-referral protocols. So when we develop this document, we made sure that we are training the midwives who are working within the district and the sub-district areas so that they'll be very conversant with these pre-referral management protocols. So what should I do when I have a case before I even refer the patient? What basic treatment should I give to this woman before the woman is referred? So that is going on. That is something that is ongoing at the sub-district and also at the district level where the patient may first report to. However, at the receiving end, the facilities that receive these cases must also have a good protocol. Again, we have developed protocols for management of pre-eclampsia, and then training has gone on for the doctors within these institutions to manage the condition properly. To manage the condition properly. They have been trained, doctors and nurses. There are standard protocols that they have been trained on, depending on the severity of the blood pressure, depending on the presence of any organ damage. What should you do? When do you transfer the woman to the intensive care unit? Or when should the woman be transferred to the high dependency unit? All these systems have been put down in protocols, and staff are being continuously trained. But I have to admit that probably the training may not be adequate and may not be very adequate. So one of the things that we'll take out from this meeting is the need to intensify training of our staff. The fact that we still have depths means that we are not doing all that it takes to do. And so we need to intensify training. We need to sharpen our management protocols to ensure that we are saving more and more lives from this condition. Thank you very much.
Thank you. Beatrice Amoa also has a question, and I would like to ask Peter Bloemenkamp to answer it. Beatrice, I'm unmuting you now so you can ask your question.
Thank you. Please, my question is, we have been doing the preeclampsia research for quite a long time. I joined the preeclampsia research 3 years ago when I joined Penn University. My supervisor is here. That time is in the Srofenyoh High. Please, my question is, why is it that we have still not found the etiology of preeclampsia? We've done a series of research. I mean, I acknowledge that all, but why is that so now we still haven't found? If we find the cause, I think that we will see the way forward. But we've been doing a series of research, but so all researchers keep saying that the etiology is elusive, we still don't know what is causing. What are we not doing right? That is the question I have for. Thank you.
Okay. Yes, and Kitty, maybe what is good to know is that Isaac also asked a question about lifestyle and poverty, and I think the both focus on etiology, so you can probably answer two questions in one answer.
Yeah.
Because we're running a little bit out of time. You asked for slide 2.
Okay, thank you, Joyce. Yeah, maybe you can share one slide I didn't show for, yeah. So about the etiology of preeclampsia, I have to say one who knows how it really does work will get a Nobel Prize. But one of the things is that we know there are several risk factors. And the risk factors to get hypertensive diseases in pregnancy are mainly obesity, underlying diseases such as hypertension, cardiovascular diseases, diabetes, autoimmune diseases. Age is, the older you get, the higher the risk is. And it's also if it's running in a family and if it's your first pregnancy. The other thing is we think there's a genetic contribution as well to preeclampsia, and probably it's the combination of the gene-environment interaction why you do develop preeclampsia. So it's a multi how do you say? It's more factors are involved to develop preeclampsia. But even women who have really, who are completely healthy can develop preeclampsia. And that's the difficulty, I think, in preeclampsia, who are the ones who are at risk, but we will have a talk on that later. And I agree, there's a lot to do in management in Ghana. When I hear the figures who are coming out from Ghana, I think it would be really helpful to have really good statistics and to go into detail in these statistics, in these data, do audit to see what's not going well, and then you can do the things like team training and so on. Is this an answer, Joyce?
Thank you. Because of time, we only have, unfortunately, time for one more question. And I would like to invite someone we've seen already in the video that Koi was shared, Mr. Dennis Ofusu Apia. And I would like to invite him to ask his question. You should be able to, I need to unmute you. Yes, you should be able to speak now. Just a minute. Yes.
Can you hear me, Joyce?
Yes, we can. Welcome.
Okay.
And we're very pleased that you're here because
Thank you so much.
As the husband of Koi.
And we are grateful for what you're doing. It's a great work. Yes. I actually want to be listening. That I think what we are driving at basically is how do we get solution to the things that we are engaged with. My thinking, because of the disease is so scary, right? Because of the nature of it. And so I am thinking of a lot of solutions, and I'm interested in that. The first thing I'm thinking of is that if we have a program in line that appears to sort of enable us to assess the history of a woman in terms of from grandparents to parent to herself, like in our situation, then what I would say is that maybe that person should not have children in a natural way at all. You should be advised to decide whether you are going by surrogate and avoid going through that process. Because in our situation, we have had 4 and we only have 1 child. The question is, how many times would you want to go through before you survive with 1 or 2? And we know the fatalities are high. And in Ghana here, as doctors have said, Greater Accra, that's the leading cause of maternal death. The other one is, the little I've heard, you are the medics, you might appreciate it better than I do. If the whole thing is that the process by which food get to the child, the unborn child, is what is blocked or poisoned, then can we find a way to get, by artificial means, to get food to the child without necessarily passing through what the body is made up of, the natural process? Is there something that we can do by that so that the child can survive? The next one is if is the case that the child, the body of the mother is so heated so that she's not in a position to contain the child. Have we advanced in the medical world so much that we can immediately take the child and baby the child through artificial process for the child to grow? Because my big brother lives in UK, and he told me a story about a child who was actually delivered, I think, less than 4 months, and that child survived in UK. But it appears that's not the case in our part of the world. It might mean, what do they have there that we don't have here? Can we get it here immediately, and how much does it cost? So that we find a way to get the money put together and buy the system to do that. So I think that if we are able to quickly, immediately be able to assemble these ideas, then we will be in position to save so many of our women and their unborn children. And I think that's my contribution that I will talk. Thank you so much.
Emmanuel, would you like to comment first and Kitty add after? There are 3 issues raised, so please be mindful.
Yes, Joyce, these suggestions, the first one has to do with what about the concepts of surrogacy. When we place this in the context of developing nation, we are not sure whether this can be a good solution, because surrogacy means that you have to go in the direction of IVF and then surrogate the baby to another mother. There are issues around it which may not be very easily culturally acceptable to the women, especially when we look at the communities. And then the other one has to do with what is at the level of the development of our neonatal intensive care services. This is an area where we need to do further investment to make sure that at reasonable gestational ages, when the babies get to neonatal intensive care unit, they survive. As he talk about a story of somebody who survived in the UK, but we have a less developed newborn neonatal intensive care system. So that is why sometimes we are forced to allow the babies to grow a little bit so that there will be some success in terms of the baby survival. Again, it's an area where further work is needed to see what is it that we can do so that the babies will survive better. So it's something that I've taken on board to think about. Thank you.
Yeah, I think in addition to this, I think when you think about why women do get preeclampsia, it does start very early in pregnancy, even at 5-6 weeks. And so we have to do something about prevention beforehand. And I think we can talk about that later. The other thing is the outcome of the babies. Yeah, that's really depending on how far you want to go. And I know in the UK and the Netherlands, we keep babies alive at a very early gestational age. But sometimes you get at a point where you really think, what's ethical, yes or no, or how is the life of the baby afterwards? So that's a large discussion about that. Should you really try to keep a baby alive at what we do now, 26 weeks, 450 grams? How is the life of the baby? So afterwards, I think you need a lot of follow-up to give an answer on this, and that will take many years. And maybe you can learn from that, from the high income countries, how that is going before starting to eat something.
Okay, thank you for your answer. I would like to propose to have a very short break to allow everyone to stretch his or her legs, get some water, coffee or tea, and we'll resume in 5 minutes with the next set of presentations. Unfortunately, we cannot have a round of applause in this digital format, but Dr. Bloemenkamp, thank you on behalf of everyone. You're more than welcome to stay for the rest of the symposium. We would really like to hear your further thoughts as well. And everyone in the chat, you can also indicate a thank you so that they can read your applause, so to say. We'll resume in 5 minutes. In the meantime, Salim, are you here?
It's actually an evening here. It's 6 p.m. here, and I will present you on a novel questionnaire-based algorithm for predicting preeclampsia. Pregnancy itself is not a disease, but the demands of it may cause other metabolic or physiological changes, which may lead to poor health and then probably cause pregnancy-related disorders. Now, preeclampsia has already been explained by most of the speakers, so I will not time my time on it. As it is known, the etiology is still a problem. However, current research actually explains that the placenta is the main underlying factor, because removing of the placenta has only been the way to remit the condition. However, you know, we only deliver the placenta after the baby has been delivered, and that will be very late. Because of the condition and how its etiology has been a problem, it has been labeled as a disease of theory. As currently it has been well explained, our basic measurement has been on proteins and blood pressure. And to some extent, we also go in for these biochemical markers when we actually realize that the person has developed the condition. But how do we tackle this? Looking at the routine biomarkers, it's still been a problem because we are not able to identify the condition, and advances in research are coming out with several biomarkers. They are very sensitive. They can predict the onset of the condition. However, these biomarkers are not readily available, and they are only used for research purposes. So the question I have been asking myself after my master's degree research on pre-eclampsia was, we have had a lot of biomarkers in place, and we are trying to identify this condition. But it's become a problem. Then it threw my mind back to trying to understand what health is. Health is not just the absence of disease, but it explains the state of complete physical and mental social well-being. And so most of the time, we actually focus more on the controls or the health and then the disease. And then we have neglected the suboptimal health, that is the state, that is the preclinical state of the condition. So thinking through my research and then my PhD research, I was looking at how we could be able to actually identify this condition using a very simple approach. Now, to understand the preclinical state of a condition, I going through our research group and then the various research that has been conducted, I realized that by the leading of our scientist or the professor or the supervisor, there has been a questionnaire that was developed to really assess the suboptimal health or the preclinical state of conditions. And that has been explained and been coined by this group of scientists who Professor Wei Wang, who happens to be my supervisor, is the leading scientist. Now they developed a questionnaire-based health screening measure. That is a suboptimal health questionnaire, which is having about 25 items. Explains the perception of health, general weakness, chronic fatigue, and low energy. And you realize that a lot of people will have suboptimal health. And that is the actual gap that we have actually left. So my project is actually a bigger scope, but I sat down and thinking through, I said, why not test this questionnaire in pre-eclampsia? Sorry, right, okay. Okay. So the idea is to move from a delayed diagnosis. That is when we have to wait till the person comes to the hospital and then he's been diagnosed of pre-eclampsia. Then we say we are starting treatment. And so looking at the questionnaire, going through some publications, it has been recognized in precision medicine. That means it's able to actually detect or has been accepted as a concept of predictive, preventive, and personalized medicine. So it's 25 base item questions that encompasses about 5 domains. This questionnaire has been really tested in about 4 major populations, and the test reliability of this questionnaire is very, very high. So the previous cohorts on these 4 major populations are in African, Asia, Australia, and Croatians. So what is actually the interest here? Based on the previous research, I have found the link between cardiovascular risk and endometrial dysfunction, which has been really associated with suboptimal health. And looking at this, it strikes my mind that since endometrial dysfunction is one of the major hallmarks of pre-eclampsia, why not test this questionnaire? So it became a question to me. I mean, part of my research, it became a question to me from the very beginning. And so I decided to test this questionnaire for the first time to really see whether it will be very, very important to identify people who are at risk, or pregnant women who are at risk of developing the condition. I further looked at whether the questionnaire has an association with objective biomarkers like oxidative stress and eugenic group mediators and other common biomarkers. And then try to look at a combined measurement of both the subjective and objective. Actually, it's the first time using this questionnaire in pregnancy. And to me, it will add more knowledge because it's a low cost, less turnaround time, and it will be readily available to really identify risks of pregnant women who are at risk of pre-eclampsia. So we started a Ghana suboptimal health cohort study for a 2-year period. We initially recruited normotensive pregnant women, about 593, and followed them up after 21 weeks gestation, and then 32 to 42 weeks. Now, assessing the baseline data alone, we tried to actually use the questionnaire to really stratify pregnant women who are clinically diagnosed as normotensive or who do not show any signs of high blood pressure and protein in urine. And so just stratifying these two categories and this normotensive pregnant women, we realized that about 50% of them are suboptimal, and compared to about only 49.9. I mean, they are really comparable. And then the first study has found out that this suboptimal health pregnant women are really associated with imbalances in angiogenic growth factors and oxidative stress biomarkers. Then what really struck me was the relationship between the suboptimal health and then magnesium and albumin adjusted calcium levels. And then pregnant women who are not diagnosed as hypertensive, but are showing high levels of blood pressure. And so it was really interesting to see that. And that moved us to look at a follow-up study where we try to look at how this suboptimal health will be important in identifying this pregnant women. So the follow-up was to integrate the suboptimal health as a criteria for pre-eclampsia. And out of the end of the study, there were lots to follow up, and then we realized that about 61.7% of the suboptimal health participants actually went on to develop pre-eclampsia. This is really a huge number. Don't be so disturbed because I mean the initial sample size was very small. And so going forward, we realized that using the questionnaire alone could be able to really identify about almost 90% of the participants being likely to develop pre-eclampsia. And then the discriminatory power, as I said, was about 0.89 area under the curve. And calcium and magnesium levels, when we looked at the suboptimal health who went to develop pre-eclampsia, they actually had low levels of magnesium and calcium at the very baseline of the study. So that led us to actually look at a combined measures of these three: a suboptimal health, the subjective and objective. That is, to be able to really come to a consensus and really understand health, we really need to actually assess both the objective and the subjective. And then putting these three factors or measures together, we realize that the algorithm is able to detect almost 80% of women who are clinically diagnosed as pneumotensive, but are likely or went on to develop pre-eclampsia. And so combining these measurements can predict about 80% of the cases. And looking at this, I can say that these measurements, that is magnesium, calcium, and these subjective measures are inexpensive. And that will be much useful, especially in our settings. The questionnaire, as I said, is the first time, or this algorithm that I've created is the first time being used. And then it's needs further research. I mean, other populations are supposed to actually look into this algorithm. And then as I was listening to a lot of the speakers, I think that we have actually not focused much on early assessment, encouraging early antenatal attendance, and then also looking into the nutritional aspect of pregnant women who comes. And I think routinely, maybe we could really start this calcium and magnesium supplementation early, and maybe not wait till they actually develop the condition. And so this, as part of my research, presented this algorithm in American Association of Clinical Chemistry last year, and it was awarded a Distinguished Abstract Award last year. And then from there, it has actually received several news mention in other publications and other radio interviews. So I would like to thank my collaborators and funding bodies for being part of this project. Thank you very much.
Thank you for your presentation. Vivian, my fellow moderator, is here now too, I think. Just to be... okay, in the meantime, I would like to give the floor to Dr. Salim Wangabi. Like last time, we will have the two presentations first and the Q&A session after. If you do have questions, please list them in the chat so we can already record them and make sure that you get the floor after. Salim, can I invite you?
I'm up already. Okay.
You're up, yes.
Let me share the screen then. Okay, here we go.
Oh, I'm sorry. I made a mistake, Salim. You're not. I'm very sorry. I was coordinating a few things in the background. Please hold on a little bit. I want to invite Dr. Salisu Ishaku. I see some nodding. Yes, others have noticed too. My apologies. I see, yes, Dr. Salisu, welcome. The floor is yours. And we will have Q&A for both Enoch and Salisu after.
How is it?
Can you share your screen as
Hello?
a screen?
Hello, can you hear me?
Yes, we can hear you. Welcome. Can you make
Can you
it
see my
full
screen?
screen? We can see your screen, and if you make it a full screen, it's, yeah, perfect. The floor is yours. Welcome.
All right, thank you very much. And everyone who is here, just like anyone here, I'm also excited to be on this platform to look at issues around women's health, especially pre-eclampsia on this special day. And over the next 15 minutes or so, I will be looking at the life course theory in the prevention of morbidity and mortality from pre-eclampsia. And I'm going to use our experience from Nigeria with a postpartum follow-up study to illustrate what we'll be talking about. So this is my outline. I'll look at what life course theory is all about, and as it relates to pre-eclampsia, and how do our practice here in low and middle income country differ from people from high income country, and then look at postpartum follow-up study in Nigeria to illustrate our argument, and then give some summary, and then end up with recommendation and conclusion. So as we know, pre-eclampsia or most of the hypertensive disorder pregnancy are newly onset hypertension, but pre-eclampsia is associated with biochemical and hematological abnormalities. Of course, pre-eclampsia is by far the most cause of death and mortality from hypertensive disorder and pregnancy. And we know that effective prevention, detection, and treatment of preeclampsia and complication actually requires a life course approach. Over the past few years, most of the effort have focused around antenatal care and interpartum care. We have not been able to put to the desired attention during postpartum period. So by briefly, let me say that life course theory of disease was initially developed to explain health outcomes as a product of overall life exposure, starting from in-children life, early life experience, early childhood experience, adolescent, and even adult life. That was how the theory was first developed, but over the years, it has been applied in virtually every aspect of medicine, including reproductive health. In reproductive health, we refer to life course theory as care, for example, to cover preconceptional period, to cover antenatal period, intrapartum period, and then the postpartum period. So we borrow idea from this holistic approach to also apply it to prevention of morbidity and mortality as a result of pre-eclampsia. And we believe that effective control of morbidity and mortality from pre-eclampsia can only be achieved if we apply the life course perspective to disease development. So I'm just using this global experience to further highlight why postpartum period should not be relegated to the background. Because right now we are not really giving much attention to postpartum period. This is the data from United States Center for Disease Control and Prevention that was published middle of last year. And it shows that actually during postpartum period, 1 week after delivery up to 1 year, it accounts for 33% of why women actually die. But typically we don't look at that. And when you look at why women die during delivery also, some of the causes are actually due to hypertensive disorder and pregnancy due to preeclampsia. So these are the reasons why women die as a result from that report. For example, overall, women die because of heart disease and stroke, and substantial part of this component is actually as a result of hypertensive disorder and pregnancy, especially preeclampsia. In the week after delivery, women die from combination of severe bleeding, high blood pressure, and infection. So you can also see the role of hypertension in pregnancy in that segment of mortality. And 1 week after delivery, up to 1 year, the predominant cause of death, maternal death, are from cardiomyopathies. And again, a huge component of these cardiomyopathies are actually result from hypertensive disorder in pregnancy, especially preeclampsia. This is also another experience from Maternal Health Task Force, where they also emphasize the fact that postpartum period has not been given a pride of place in our attempt to prevent maternal mortality. From the account, they believe that greater than 60% of maternal death actually occur during postpartum period. And it is believed that continuity of care from pregnancy through the postpartum period is essential for preventing maternal and newborn death, including those due to hypertensive disorder in pregnancy. So, but now that we all know that postpartum period is an essential component of maternal health, what is the experience now between high-income countries and low and middle-income countries like Sub-Saharan Africa? We discovered that application of life course theory to managing pre-eclampsia varies across this region. Most countries in high economies, actually, to some extent, they have a dedicated guideline that include management of pre-eclampsia during postpartum period. We don't have those guidelines in our region. This is mainly because, in the first place, we don't have our dedicated guidelines. What we do commonly, we use the World Health Organization guideline to manage our women. And unfortunately, again, the current WHO guideline for pre-eclampsia management does not include postpartum period. And as a result of that, we don't give much attention to postpartum care needs of women when they develop pre-eclampsia after delivery. To illustrate what I'm talking about, I just want to share an experience from a study in Nigeria that was conducted on postpartum follow-up of women with hypertensive disorder in pregnancy. And this study was conducted in 8 tertiary hospitals. 5 of them are teaching hospitals. So we assume that care in these hospitals actually should be the best in theory, that if women go to this hospital, they will receive the best possible care available in Nigeria. That is theoretically, because these are teaching hospitals, these are tertiary referral hospitals. In that study, we recruited more than 400 women with hypertension and pregnancy, and wanted to determine what is the degree of adherence or compliance to international guidelines as it relates to postpartum management of women with preeclampsia. And we also want to determine prevalence of persistent physiological derangement, something like persistent hypertension, issues like some metabolic problems, and see whether truly these women continue to exhibit complications of pregnancy during postpartum period. These were the 2 main objectives. This is just to tell you the data collection process from the baseline at delivery. We look at this woman at 9 weeks, at 6 months, and then finally at 1 year. And during this period, we collected information, both clinical and laboratory information. So this is one of the things we're talking about. When you look at this bar chart, it just shows us that these are women with hypertensive disorder and pregnancy whose blood pressure were measured and documented in the first 5 days of delivery. When you look at it, on the first and second day, more than 80% continue to get their blood pressure measured and documented. But after the second day, the proportion of women that receive these services dropped drastically, so that by the 5th day of delivery, more than 60% actually were not, their blood pressure was not measured. That is just to illustrate how careless we are generally in this part of the world in terms of managing women after delivery. We do everything during antenatal period. We do our best during delivery, but after delivery, we seem to relax our care for this woman. So this is one example. And this woman, we are not, their blood pressure was not measured because they were normal. No, blood pressure in this woman continue to be high, as you can see from this slide. When we look at, for example, preeclampsia, women with preeclampsia continue to have high blood pressure at 6 months, at 9 weeks, and even up to 1 year. But nobody is checking their blood pressure. So this is really a concern in the way we manage women with hypertensive disorder and pregnancy. Not only preeclampsia, also coronary hypertension, gestational hypertension, and those with eclampsia. And these are the proportion of women with moderate to severe hypertension in the first 1 week of delivery who should have been on antihypertensive, but who are actually on antihypertensive. So when you look at it, when you look at, for example, women with eclampsia and preeclampsia, over 60% of them, over 40% actually, we are not on antihypertensive, and they should be on antihypertensive. And this is only the first week of delivery. So by the time you look at what happened to them in the second week and third week, you discover that the coverage will certainly become worse than what we see in the first week. And these are other aspects of quality of care that we also looked at. For example, we look at if women, if their babies receive neonatal care after delivery, because it's part of the component of care for this woman. And you can see that only like 50–55% actually got that care. And when you look at it, it's the same for all other indicators that we have measured. And it's even worse for women with preeclampsia who actually remain hypertensive after 2 weeks, who should have been given medical review according to most guidelines, but only 20% in our study received this care. And we felt that this is really, really very bad because we are talking of women who are receiving care at the highest level of care in the country. This is the same information from what I spoke the other time, but in a different way. So I will just skip over it. And this is also, we look at women who continue to have risk factor for future cardiovascular health, for future endocrine problem like diabetes mellitus. And we see that lots of these women actually exhibit high percentage of these women continue to show evidence that they are actually at risk of those future health status. They remain proteinuria at 1 year. BMI was generally high after 1 year, high level of cholesterol, triglyceride, and other biochemical indicators. So this means that, one, risk factors are high in our women. Our women continue to have physiological derangement, but yet we are not doing anything about their condition once they deliver. Because to also show you that, to demonstrate the fact that postpartum care generally is not given a pride of place, information on how women were managed during postpartum care, especially when they have preeclampsia, is generally scarce in this region. Nobody is doing anything about it. We didn't get any information in Sub-Saharan Africa and Southern Asia, but we lay our hand on a program report from Bangladesh by Sharif Mohammed and his colleague, where he also documented their experience on the quality of care that women receive after delivery. And most of their finding actually exactly to our finding in Nigeria. And we believe that that will be the situation in many countries in Sub-Saharan Africa and Southern Asia. But whether we have information from there or not, there is a WHO systematic review that actually indicated that in general, there is inequality in the coverage of postpartum care between high-income countries and low and middle-income countries. And this is enough to tell us that the laxity in care in our region is actually a fundamental problem that we must look at. So in summary, we should know that there is huge inequality in the provision and access to postpartum care among global economic blocs, and especially for women with hypertensive disorder in pregnancy. women in high-income economies are actually seem to be getting the care, not optimal, but they are getting some kind of care, while we do not get that kind of care in our setting. And because of poor postpartum surveillance in our region, health outcomes for these women are actually unknown, are undocumented. So we will not be able to say anything about it because we don't document them, we don't know what is happening to them. And this inability to care for these women during postpartum period will certainly jeopardize their future pregnancy outcome and also other health outcomes. So we need to do something about that. And preventing morbidity and mortality from preeclampsia can only be successful if women are attended to holistically, right from preconception period, antepartum period, intrapartum, and postpartum period. So maybe to develop on what Emmanuel just presented, that in Ghana they are thinking of having eclampsia matrix to their practice, maybe you should also put more effort in seeing that every woman that develops hypertensive pregnancy must be tracked during postpartum period until everything becomes normal or until she is referred to family care or other specialist care. Because these women go out of our care and we don't know what happened to them and they are undocumented and we cannot account for their health status. So, so I have these 4 recommendations. One is that we recommend that Ministry of Health, especially in our region, should be supported to develop dedicated guidelines for women with preeclampsia during postpartum period. And after that, there must be, in addition to postpartum care, women with preeclampsia should be advised to receive preconceptional care in order to recover, to receive the entire care along the entire maternity spectrum. And these guidelines, once developed, should be followed with a tailored on-the-job training and mentorship for frontline healthcare providers. And finally, we must continue to rigorously evaluate the benefit of these guidelines and appraise them on an ongoing basis to be sure that the guidelines are actually delivering what they're intended to do. Or if we need modification, we can actually modify this guideline. Thank you for listening, and I will be happy to answer any question from this presentation in due course. Thank you.
Thank you very much, Doc. It's been a good presentation. So we'll now open up for questions from the 2 presentations we've had so far, from Enoch's presentation and from Dr. Salisu's presentation. We have one from Nana Ampofo, who would want to know how long you suggest the postpartum tracking of a patient should be. Dr. Salisu, could you help us with that?
Yes, thank you very much. And traditionally, we assume that after the puerperium means that a period from delivery until 68 weeks, that most of this biological derangement will actually went off. The woman will be normalized after 68 weeks. But in reality, these conditions are not going to go away, especially hypertension may not realistically disappear in all women until at least 3 months. But that should not be our yardstick. The yardstick is that for every woman, she must be continue to be monitored until all these symptoms and signs disappears. And if after two months, there is no improvement in their disappearance, then women should refer to specialists, dedicated specialist unit for further management. But certainly some of these women will receive lifelong care. You have to remember that.
Okay, thank you very much, Doc. Do we have any more questions? So, Evelyn, can we hear the question from Evelyn? Hello, Evelyn.
Yeah, hello. Thank you very much. Dr. Salisu, The question I'd like to ask is, what measures are you putting in place to track women who refuse to come back for aftercare services? Because in Africa, I'm in Ghana, some of the women will not come back to the hospital after delivery. And so what are you doing to track them? Because if they are not coming, you also can't give them the care. So what do you think can be done to encourage women to come back for the postpartum care period?
Thank you, Evelyn, for your question. I think what we observe is that we also don't counsel them and let them understand the implication of their health and what they need to do. We don't do that. In my presentation, I did not give many information because for lack of time, but if I had the opportunity, you can see that when we trying to find out whether women were counseled in terms of their future health, in terms of the risk of occurrence in the future pregnancy, in terms of whether they should use contraception or they should control their body weight, we discover that more than 80% of women were not given that information. So truly, if we counsel women, no woman wants to die. If we counsel her, give her enough time that this is something that she can actually lead in her own care, and she can do it on her own way with the support of the health system, most of them will actually comply. So we are not given the counseling.
Okay, of course, no woman wants to die, not when you are giving life, you are giving birth. I mean, you are carrying a new life. Nobody would want to die. Thank you on that point, Dr. Salisu. Karen wants to find out whether you have considered using mobile health apps, mobile phones, apps on health on mobile phones to track and follow your women.
No, but women in the research, for the purpose of the research, yes, we actually use mobile phone, and that really actually increased our follow-up rate because we have a follow-up rate of up to 1 year of 70%. For a cost study to have a 70% follow-up in Sub-Saharan Africa, you know that we really it did very well, and part of that success was as a result of that mobile tracking.
Okay, so then we agree that using a mobile phone app could also help track these women, especially when they realize their BPs are raised, and then they could be followed and encouraged to come back to the health facilities. From Hafiz Muntala, Hafiz would like to know if any attempts so far have been made to get the suboptimal health model of Dr. Odame integrated into our maternal health services. I'm not sure whether Dr. Salisu could answer this.
Dr. Enoch, probably.
Yeah, hello. As I said, it's a new questionnaire used in for the first time in pregnancy. Currently, what we've been able to generate is a QR code that once you're able to scan the QR code, you'll be able to, the questionnaire can easily be available to you on your mobile phones. That is how far we've gone now, but has not yet been actually included in our health. It has been a current discussion in the school, and currently the suboptimal health integration into clinical health research has been one of the major research area that has been accepted by the Edith Cowan University, and we are trying to liaise with other health professionals here. But I think in the Ghanaian settings, because it's a first time, I don't think it has been used, and it hasn't been used anyway. So, yeah, let me clarify.
Maybe for those, if I can add something, for those who are interested in prediction models and the integration in clinical care, in the chat I listed two systematic reviews that have been recently conducted that list all the available prediction models. Most are too early to implement because they have not been externally validated, meaning that they have not been assessed for how well they perform in different settings from where they were developed. And that's a crucial step before implementation. And then when it's implemented, it also needs to be evaluated for its effectiveness. And in the second systematic review, this is also extensively discussed. So there are a few very interesting resources if you're interested in this topic.
In addition, Dr. Bonsafo would like to make a comment.
Yeah, thank you.
Bring in his comment, and then we could.
Thank you, Vivian, for the opportunity to make a comment. First of all, I want to take the opportunity to say thank you to the organizers and the invitation, and also to invite all of us to kind of be part of it. I think secondly, I want to congratulate the presenters for a very good work done. I was going to talk about the comments that Joyce made. This innovation by Dr. Anto is very good, just that, as she said, we need to kind of validate it internally and externally and assess the impact. And then when it is finally agreed that externally is performing well, it could be integrated. So it's a good innovation, which we have to kind of congratulate him for doing, and then we may be able to integrate that into our work, I mean, in future. And then the Ghana Health Service, I'm sure, will be very happy to kind of welcome it, I mean, to the management protocol. The other thing I want to talk about, I mean, to add to Dr. Salisu's presentation, is that we know that pregnancy and pre-eclampsia actually is the cardiovascular effect, I mean, can occur days and years. And so we should not really think that after delivery, we need to just monitor them for 6 weeks and leave them. Even after 1 year, these women actually, they may have had endothelial dysfunction that kind of may predispose them to development of some cardiovascular disease in future. And we should continue to look at that. We are happy to see the work of Salisu, because it's an area that people have actually neglected. Obstetricians, after delivery, they think they are done. No, you are not done. We need to follow up. We think once we are able to deliver a healthy mother and a healthy baby, we are done. We need to look at some of these things and then move on. Lastly, Dr. Anto, you were surprised to see that there was a lot of endothelial dysfunction in women, even though those who were just pregnant and had not developed pre-eclampsia. It's something that we have also found out, especially when we did study vascular endothelial dysfunction by measuring nitric oxide levels and vascular endothelial growth factor levels. There were evidence that actually comparing those who are just pregnant, they have some form of dysfunction, and it was significant when compared to non-pregnant women. However, it was far higher when you compare to people who had developed a pre-eclampsia. So these are things that we should be looking out for, and in future, I hope we'll be able to work hard and be able to improve maternal health for women who develop hypertension in pregnancy. Thank you very much for the opportunity.
Thank you.
Okay, thank you very much, Doc. We'll take one last question. Dr. Salisu, so a participant wants to find out whether there is a roping program for husbands, especially husbands in the sub-Saharan Africa, because he thinks getting husbands in would help achieve more maternal health, like a better maternal health care for women. What do you have to say on that?
Yes, again, thank you very much. But we also know that this is research, it's not a program per se, but using husband in Nigeria has widely been utilized in family planning, but hasn't been done, it hasn't been employed in other areas of maternal health. But even in this our study, actually, we actually enroll a woman and then use our own mobile contact as the primary means of contacting her. And then secondly, too, we collected the husband number. And personally, myself, I have reached out to many women at least 15 women through their husband. So yes, I agree with that. That certainly men are actually important collaborators in this effort, and certainly men's involvement is always a key component of what we should be doing in Sub-Saharan Africa.
Okay. Joyce?
Okay, so thank you. So with this, we would like to conclude this part of the program, and we would like to invite the next speaker, Salim Wangabi. Now you're up. I was too fast before, but now you're very welcome. Please share your screen and share with us your presentation. While you do this, maybe as a background, Salim Wangabi is a clinical psychologist at the Greater Accra Regional Hospital and a strong advocate for maternal mental health care for pregnant women, especially after they've gone through hardship. And he set up with his team a program for mental health for women who are pregnant. The floor is yours.
Thank you, Joyce, and thank you all for being a part of this webinar in commemorating Preeclampsia Day. I think it's been very insightful listening to previous speakers from Dr. Srofenyoh to Odame and Dr. Salisu and Prof. Kitty. And it brings to bear the importance of having to understand what pregnant women do go through and what we can do as health professionals to aid them. I'll start with my presentation by talking a bit about expectations of a pregnant woman. For every pregnant woman, once she has decided or accepted the pregnancy, there's a hope that she will deliver a baby without any complication, healthy. And in our part of the world, Ghana specifically, on the 8th day after her delivery, we are expected to make merry, bring gifts, and then commemorate the good job she may have done by bringing another life to the world. And then also, usually or most of the time, childbirth in any family or to any partners serves as a tightening of a bond between the nuclear and the extended family system that have these children. So then pregnancy is most of the time viewed as a time of elation, time of happiness, and because a newborn is going to join the family. However, the reality is that pregnancy does not come the same way for every woman. So sometimes it's a time that is filled with stress, worry, as well as numerous emotional upheavals and changes. Because of hormonal changes, sometimes there are mood changes, there are changes in work schedules, etc. So though the expectation is that it will be a happy moment for every woman, the reality is that we do not expect women to go through pregnancy without any challenge. And interestingly enough, research by Gray in 2006 shows that many pregnant women develop depression during their pregnancies. Why? Because there's sometimes alteration in their appetite and weight, change in sleep patterns. Sometimes there are thoughts and feelings of weightlessness, decision-making becomes difficult, etc. And so therefore, the reality is that pregnant women, even before diagnosis of preeclampsia, would have some psychological or mental health distresses. The World Health Organization is estimating that 15.6% of women will experience mental disorders during pregnancy. But how often are we able to pick these things as healthcare professionals? And sometimes pre-pregnancy history of depression or anxiety is also a risk profile to preterm preeclampsia, as Madavi noticed in his research in 2015. For non-pregnant women or males, the research is non-equivocal when it comes to the role by which the hypothalamic adrenal axis and the pituitary gland plays in hypertension. So if you have consistent or regular anxiety as a normal person who is not even pregnant, the risk factor of developing hypertension has been found out in research, and therefore people who undergo a lot of anxiety because of the sympathetic nervous industry continuously, there's going to be some hypertension. But when it comes to pregnant women, the research is a bit equivocal. Some research will say it's a risk factor, others are saying no. Why? Because the data collection and the time of assessment differ. And there are other factors that impact the quality of life of a pregnant woman, especially when diagnosed with preeclampsia, because the socioeconomic status she comes from or the background, her educational level. I think in Dr. Srofenyoh's presentation, he mentioned that in our part of the world, women do not get the ability to just go online and read certain things about their pregnancy and what they can do. So depending on the educational level, the socioeconomic status, there are challenges they will face even when they have been diagnosed with this condition. So in screening for preeclampsia, we sometimes, or most health professionals, might miss the distress or the difficulties or mental health challenges these pregnant women might have. Now, once you've diagnosed or noticed that a pregnant woman has preeclampsia, first of all, this is bad news. And whenever you have disclosed a bad news to a person, especially who is pregnant, we are expecting a change in mood. And when this change in mood is not managed in such a way that there's adaptive coping, we are expecting some distress, which might become depressive or anxiety later on. Research from BMC pregnancy that 1 in every 5 women with preeclampsia had postpartum depression, and its magnitude increases with the severity of the disease. So though maybe during the pregnancy or during the diagnosis, the mothers may not have shown significant mood changes or distress, the research is saying 1 in 5 would go ahead to develop this postpartum depression. So there's a need that attention to their mental health during those times, because maternal mental disorders are a risk factor for the child's health also. So beyond the mother, if she goes through this traumatic phase of having to deal with preeclampsia, and as we all require, she gets the baby through a very good intervention earlier on, the development of the child as well as the bonding between the mother and the child can be affected by her mental state. And mothers with postpartum depression have some difficulty sometimes caring for their kids or the infants or children they bring to the world. Now, when it comes to the management of pregnant women with preeclampsia, there are very key things I would also like to espouse in this presentation. There's a need for us to screen the mental health of these mothers as early as possible to pick any significant challenges they might be going through in the area of depression, anxiety, and sometimes post-delivery or post-pregnancy, whether there are any signs or symptoms of depression or anxiety that were missed. And in the provision of treatment, unfortunately, in our part of the world, the availability of mental health professionals to deal with the number of mental health cases we have is a bit on the low. So for most of the times, even when pregnant women have been referred to see a clinical psychologist, it may take a while before they get a date and everything. So there's the need for us to also develop modes by which pregnant women can receive mental health treatment or support without necessarily having to go to individual therapy. So there's a need that during this pregnancy schools and the rest, there's some education around mental health and how they can do group therapy and pick up some of these skills they would need in managing their preeclampsia and mental health during pregnancy. Now, there are other factors we can also consider, such as young age, marital status, family support, etc. Because most of the time, though it's the woman who gets pregnant, the support from the partner or the spouse will be needed. For most cases I have seen here in the hospital, you notice that some women in some parts of the pregnancy were left alone and people expected them to be strong. But sometimes just providing them with a listening ear to vent their sadness, to vent their emotions can go a very long way to prevent subsequent disorders when it comes to dealing with the mental health of pregnant women with preeclampsia. The statistics are likely to underestimate the scale of the problem. So most of the time, because we do not recognize or detect them quickly or even notice them happening, we tend to say it's not there. But unfortunately, mental health might be individual rather than group related. And also because of maybe lack of some policies and partnership between relevant stakeholders. For instance, in the health sector, there are different professionals. When there's no proper collaboration between the teams, we tend to miss some of these important symptoms or challenges pregnant women diagnosed with pre-eclampsia might be going through. So I have some proposals or things I feel when we do as healthcare professionals, researchers, and stakeholders working around pregnant women, especially those diagnosed with pre-eclampsia, will go a long way to help mothers or pregnant women. There's a need to make known common non-psychotic mental disorders pregnant women go through. So the education, sensitization, like I said, during the maternal clinics and schools, etc. There's a need to introduce the education and sensitization when it comes to their mental well-being, what to notice, what to report, and also identify factors that predispose them to these challenges. Because like I said, based on the socioeconomic status, educational level, cultural differences, some mothers or pregnant women might be going through some difficulties that goes to exacerbate their pre-eclampsia or conditions, and therefore leads to other complications. And when it comes to the healthcare professional, there's a need to assess that mental health during the antenatal clinics. So here at RAGE, what we do is in our health pro systems, we have assessment tools for depression and anxiety, such that every doctor who is reviewing a pregnant woman at the antenatal clinic has the opportunity to ask these questions. And when she has recorded significant distress in the area of depression or anxiety, then he or she could refer to the clinical psychology center, where she would be given some attention and then treatment if possible. Also, even post-delivery when they are on the ward, these systems exist to help them. And also there's a need to increase the studies, because like I said, when you look at the research on mental health, pre-eclampsia and pregnancy, it's a bit equivocal. You find one research saying it's a risk factor, others saying no, it doesn't play a critical role in the hypertensive or pre-eclampsia levels. So there's a need for us to focus more attention on research, collect the data at different intervals of the pregnancy, control for a lot of the factors, and then going forward, we can be very objective in making statements and knowing the help we need to provide for pregnant women who have been diagnosed with pre-eclampsia. Thank you very much for your attention. I'll end my presentation here.
Thank you very much. Are there any questions? I saw one question by Muriel Harris. I'm going to unmute you so you can ask your question yourself.
Thank you. Thanks very much for the presentations. I've actually enjoyed them. I'd like to ask a question to the last speaker. And my question is there an opportunity to develop care teams? So a woman has more than just her physician or her clinician, because I think that may be an opportunity to expand her opportunities to talk to other professionals and other professionals to identify problems early on, so that she may be seen in a more sort of holistic light than just her clinical condition.
That's very true. And here at the Accra Regional Hospital, it's one of the things we are working towards, even in the sports impact study, so that it's not just her medical team or the nurses she's seeing, but other professionals such as the clinical psychologists, the dietitians are always present to also review and provide help and assistance as and when it's needed. And sometimes also it's very important to include the significant others. This might be the spouses, the mothers, and those who also aid her in ensuring her well-being. So yes, something we encourage and work towards.
Thank you. I'd just like to make a follow-up comment about the public health component. It seems from a lot of the presentations that that's going to be critically important. So even thinking about how public health professionals can be incorporated into some of this thinking and trying to identify some of the issues, especially the socioeconomic factors or sociocultural factors that influence health, bringing them in also to the research and into the clinical practice may also help to minimize some of these issues. I actually spend much time in Ghana, so I have a pretty good understanding of the conditions there. But thank you very much for the opportunity.
Thank you for the inputs.
Evelyn Tama, I see you have your hand raised. Would you like to ask your question?
Yes. Hello, can you hear me?
Yes, we can.
Yes, Salim, good presentation. The question I'd like to ask is there a follow-up structure for women identified with postpartum depression? The reason why I'm asking this, I observed labor in one of the hospitals where a lady asked us to give her 1,000 cedis and take her baby. Practically, she was selling the baby to us. So I asked the midwife, what would be the outcome of this lady? And then in the end, I observed that she was discharged. She left the hospital by herself with a baby. And I asked the midwife, so what happens? Because this woman could abandon the baby anywhere. And she's also not even in a state of mind to be discharged. But unfortunately, they told me they needed their beds. They don't have any family member. So do we have a very good follow-up structure so that our women are followed up after they've been discharged?
I wouldn't say we have a very good structure, but it's something we are working towards. So even beyond admission, there should be a system for all hospitals. So if for regular calls or check-in for these pregnant women. And also, like I said, we are working at starting this group therapy for pregnant women, mothers who have delivered, so that when they go for these meetings or group therapy sessions, they get to pick these skills, and those that are significant then receive the individualized therapy. Because like you said, sometimes the stress or the depression might not be significant enough, and therefore with a little help or skill training, she would be fine. But some of them may have moved to certain levels that might actually need a specialist to see them. And so, yes, the follow-up system is not the best, but we advocate and are still working at expanding it so that beyond discharge, there's a follow-up, there's a course time. And also because they come for reviews, I think every week or 2 weeks after delivery, we here at Rich insist that when they come also, they should do a review with the clinical psychology center to keep us updated on how they are doing and the distress they might be going through. I hope I answered it.
Okay.
The next question is for Nesia Taylor. Nesia, if you want to ask your question, you can. Or I can ask your question for you. Nesia was wondering if there are screening tools available, questionnaires that can be used to screen women for mental health disorders.
Yes, there are a number of them. Some of them actually are free online. There's the hospital anxiety depression skills, there's the Harvard trauma skill, a number of them. So if you go online, you find tools that aid you to assess. So now, assessment of mental health disorder sometimes goes beyond just using of the tools, but also observation and sometimes history taking. So that's why we say that when you do this assessment as health professional, maybe as a nurse, a doctor, you look for a score. Once it's significant assessing point, then you refer to the professional in that area to also follow up. Because sometimes people who have knowledge of these tools can sometimes provide answers so that it doesn't look significant. Because one of the challenges of mental health is also denial because of the stigma attached to it. So some mothers, though they might be going through some difficulties at home or some depression, would not open up and talk about it. Because sometimes they feel, well, I don't think I would get help. Why should I open up? And so once you've seen those signs, yes, the tools are good. You start with them, you assess them, and then refer appropriately so that other healthcare professionals can take over and provide help.
Thank you. Before we introduce our international surprise speaker, there's time for one more question. And I see Frank put up his hand. So would you like to ask your question, Frank Nitako?
I hope you can hear me. I am very much impacted by this presentation, especially with the mental health side. We live in a country where mental health issues are usually relegated to the background. Mine is actually a comment, or more or less an addition to the presentation. I feel that the involvement of husbands, for example, should be intensified. But like you said, in a part of the world, husbands tend to control virtually everything that happens in the house, in the family. But we are in the hospital setup and you see women or wives, pregnant women alone coming to the hospitals and assessing the care, they're going through all the struggles alone. And the men don't seem to care because they are out there only looking for money. I feel that in a normal situation, when a woman sees the husband around, going through this stress with the husband, she becomes more fulfilled and enjoys the service than seeing the healthcare professionals. So my comment is that there should be a policy that will actually bring husbands on board to support their wives. It will be a great thing. The second thing I have also realized working in the hospital myself is the disjointed services that we see. I usually see clients going through different units, going through a doctor, the hands of a nurse, a midwife, the lab person, and it looks like each unit or department is offering the services disjointedly. Nobody seems to care exactly what is happening. I feel the time has come where, for example, in my facility, you realize that women who are in this situation with pre-eclampsia, usually you find them with their own samples, going to the lab. In my hospital, for example, a big hospital, that clients will have to move from one point to another, frustrated, not even knowing exactly where the next point of service will be. I feel that there should be a clear system that will more or less control and monitor all these systems so that clients will not have to suffer. Already they have their depressions already. If they have to go through these services, and then the service which is supposed to make them better is even adding up to what they are going through, then I don't think it's happening. So my contribution is that there should be a policy, in fact, an intensified one, that will make sure that not just a doctor sits in his own consulting room and takes care of the patient, the nurses in the ward or anywhere also offering her bit of it, the lab person offers a bit of it, and we all leave the patient in degenerated conditions. There should be a way to monitor all these things so that the client will not suffer as a way of even offering services to this client. Thank you so much.
Thank you. Salim, would you like to respond to this?
No, I think it's a good comment. So like I said, social support during pregnancy and post diagnosis of preeclampsia cannot be overstated or understated. It's very important. But sometimes there's a bit of dynamic you also want to look out for. Inside the pregnancy will not be the same for everybody. There's lots of privacy and confidential issues when it comes to patients. You want to also seek permission from the pregnant woman as to who she wants to come in, and not to draw in people who she's not comfortable with, because though there might be a relationship, you don't know what's going on at home. So yes, it's important to bring in everyone who would be able to support them, and let's do that also with some caution, taking consideration of their privacy and confidential issues. Thank you.
Thank you. And again, thank you, Salim Wangabi, for joining us to talk about mental health, a underappreciated topic in hypertensive disorders, and in part because of all your efforts, has a really steady increase on the agenda, the research and clinical agenda in Ghana, and it's a reflection of the world, fortunately a world where we have more attention for this. As everyone could have seen, there is a new PowerPoint up, and it's for our surprise international speaker. On behalf of the organization, I'm really proud to introduce Professor Andrew Shennan to you. He's a professor of obstetrics at King's College in London and based at St. Thomas Hospital. I'm sure he will give a more elaborate introduction himself. What I do want to highlight is that he's quite familiar with various sub-Saharan African settings and clinical settings based on his childhood that took place in a number of sub-Saharan African countries. Professor Shennan, the floor is yours. Very welcome.
Good, thank you, Joyce. Can you hear me all right? Good, fantastic. So I'm going to give you about 20 minutes, I think, if that's all right, 20, 25 minutes. I saw on the program, so if you're happy with that.
Yeah, that includes a Q&A session. So.
All right, so I'll keep it down a bit to 20 minutes, thank you. And so I'm absolutely delighted to be asked, and thank you for inviting me to come and talk to you, because I'm a firm believer that you guys are working in the most important parts of the world, and you are the ones that are going to make a difference. So the opportunity to be able to talk to you and share some of the stuff we do and thoughts we have is just phenomenal. And I also just wanted to congratulate APECGH Ghana, because you've kind of led the world in setting up a very functional organization, and we've been really looking forward to engaging further. And in fact, we're trying to emulate exactly what you've done everywhere else. And I'll talk a little bit about those initiatives during this talk. So I just wanted to kind of acknowledge that and congratulate you all. So I'm an obstetrician, so I work in London. I'm an academic, so I kind of have a university appointment, and I spend a lot of time doing research. And one of my passions has been to look at problems related to maternal mortality, and one of my other great interests has been in pre-eclampsia. So I've kind of married those two ambitions to try and look at pre-eclampsia in low and middle income settings, sort of the global south and so on. So I just really wanted to, I'm sure you know, you're very familiar with pre-eclampsia, but just wanted to very briefly go through some concepts around it, which is why I think some strategies are good for us in preventing the problems in a global setting. So we all know pre-eclampsia is this sort of has this insidious onset that is very difficult to know when it's going to happen. But we do know that the pathology of it starts quite early on, probably related to the placenta. And then at variable times, people will get high blood pressure and protein. And one of the hallmarks of safety is to identify blood pressure and or proteinuria in order to target those who need attention. And that strategy works incredibly well. So a huge amount of what we do is about accurate determination of blood pressure and protein and making sure those people are seen regularly. So that's a key component. And what is pretty common is that you don't always get symptoms afterwards, but you do have a crisis. And the crisis often happens in a few days, particularly with early onset preeclampsia, but certainly no more than 2 weeks, even with late onset preeclampsia. And that crisis means something to the mother, something to the baby that results in death, requires delivery to prevent that. And so therefore timely sort of identification and getting the baby delivered is what is key. And that is a very tight time frame. In fact, we've just finished a trial in the UK called Phoenix, published in the Lancet recently, showing that if you get preeclampsia at 34 weeks, the average time to a disaster is only 3 or 4 days. So we know that if you get the diagnosis right, you can reliably know that person's going to run into trouble, and delivering them, even if they're premature, may be justified because there'll be a disaster otherwise. And we've used this strategy in terms of developing new blood tests, which I won't go into today, but that's something we're working on in the UK. But what I will go into is some of the issues around mortality around the world and how it's been reduced. We're very proud in the UK that in recent years, from 2008, we have dropped the mortality in preeclampsia to virtually nothing. So 1 in a million people die from preeclampsia, and there are virtually no substandard care now. But in the 1950s, up to about the 1970s, the way that we improved things was basic healthcare structures and identifying people. And our universal healthcare structure, making sure everyone gets a check, has been the hallmark to success. So we haven't got a magical treatment for preeclampsia. We just identify people and deliver them in a timely manner. And it's very rare for sophisticated care like ITU care to make a difference. And so this is a really important principle. And when you go to the rest of the world, you can see that Africa and Asia really has the sort of lion's share of the morbidity and mortality of preeclampsia. Yet the success in the high income countries is dependent on healthcare structures. So even in the UK, we have 15 times lower mortality than the US. And I think the difference between those two is not the sophistication of care. It's just that we have universal health care that everybody gets. which does not happen in the United States. And that makes a massive difference to the success of mortality and prevention in preeclampsia, and a very sobering lesson, I think. But those lessons can be translated around the world. And I just want to share with you this data, which is data from one of my trials where we've looked at death rates accurately, prospectively in low and middle income countries. And this is published in March last year, showing that mortality does alter a lot according to hypertensive disorders around the world. And some countries will be, 4 or 5 times worse than others in a low income. So that there are big differences, and they are largely attributed to simple measures like just getting blood pressure measurements to the right people. But I want to show this data in the context of coronavirus, because, the whole world now is having to deal with this problem. In the UK, it is rare for women to die from pneumonia, and it's rare for them to die from influenza. And in this particular bar, you can see the dark bar are those non-genital tract sepsis deaths. And what I've done is I kind of looked at this in a little bit more detail. I thought you might find it interesting in the current pandemic. You can see from this graph that the people who die from coronavirus so far are those who tend to be older people. So those over the age of 60, the rates escalates. However, if you compare it to influenza, so the pandemic of 1918, you can see that women of reproductive age between 20 and 40 were much more likely to die from influenza than they were from coronavirus. So to me, this is quite reassuring for pregnant women. Pregnant women on the whole do not have a very high risk of dying from this. And the reason I mention this is we have to put this in perspective to preeclampsia. Now, I've just worked this out recently that the deaths from sepsis in the UK from pneumonia and influenza is very rare. So 1 in 220,000 people die in pregnancies. We've worked out from our UCOS data set from the UK, where we had 80,000 deliveries in 6 weeks, there were only 5 maternal deaths from coronavirus. So that means the chance of dying from coronavirus is 1 in 16,000. So that's pretty low. It is true that women from different ethnic groups were more at risk, but only 4 or 5 times more at risk. So even if you took that into account, the deaths from coronavirus are relatively modest compared to, for example, the average deaths from preeclampsia. So if you take the average deaths from low and middle income countries, it's 1 in 2,000. So it is literally 8 times higher than the coronavirus deaths in the UK. And we haven't got a cure for coronavirus, and our treatment doesn't necessarily make a difference. So actually, I think we have to keep this in perspective, that treating preeclampsia in the environments you work in is probably more important than coronavirus. That, I think, is a fact. I'm not saying coronavirus isn't terrible and we have to be careful, but what we mustn't do is stop normal antenatal services because of this problem, and that is obviously a challenge with this happening. And what's happened in the UK is that we're down to 1 in a million, and we're just really worried people aren't accessing care and that the death rates are going to escalate now. So this is something that I just wanted to kind of point out to you. And just to share with you our experience in London, in our hospital in the UK, we've only had 30 positive cases, and we are in the middle of one of the worst areas of London, London being the worst part of the UK, ahead of the curve of everyone else. And other than New York, I think this is one of the worst experiences in pregnancy, yet it's not that bad. In the last 2 weeks, we've tested 180 women coming through the door who've been admitted. There wasn't a single positive case. So our strategy of isolating seems to have worked, and we only had 3 sick women and nobody died. So I think this is kind of a good news story, and virtually no vertical transmission to the baby. And again, if you look at this now, you can see that we've only had a sporadic number of cases over the weeks. Now, I wanted to talk a bit about prevention of preeclampsia. I think you all know the aspirin story. We know that low-dose aspirin prevents preeclampsia if given to high-risk people. I just wanted to share a couple of slides with you that that may be of interest. We know how it works by this favorable thromboxane prostacyclin imbalance. This data, I think, is worth sharing. I think you may know it, is that if you give aspirin at nighttime, people do better. And we're not entirely sure why, but you can see for all these outcomes, they are better if you give aspirin at night. And because that's such a simple thing to do and to recommend, it's something that that's worth clinicians knowing. We also know that the dose of aspirin might be crucial. In these studies, we know that if you start giving slightly higher dose, maybe up to 150 milligrams, the outcomes may be slightly better. And so that's something that we are now considering in the high-risk cases, although 75 milligrams has the best safety profile. And in the ASPRE study, which is a European trial mainly, giving 150 milligrams early on from 12 weeks, finishing at 36 weeks, and giving it at nighttime, targeting it to people who have problems indicating they're at risk of preeclampsia does mean it works well. And you could see that in this study, there's a 90% reduction in the early onset preeclampsia, which is what we really want. And also in the preeclampsia that occurs before 34 weeks, an 80% reduction and a 65% reduction before 37 weeks. So all a good news story, including reductions in things like abruptions. And this paper I think is quite interesting. So this is actually in a low income setting. You could see that aspirin was given routinely to all nulliparous women in a low income setting as in an attempt to reduce preterm birth. But the way it reduced preterm birth was by reducing the need for early delivery from the hypertensive disorders of pregnancy. That was its main action. And you can see in this slide that there's an over 60% reduction in early onset hypertensive diseases in women who routinely got 75 milligrams of aspirin from early pregnancy in a low income setting. So these authors are advocating that maybe we should be giving out low dose aspirin more readily. The challenge, I think, for low income settings is targeting, getting it, the pharmacy of it and getting it to the right people early enough. So, but it's interesting data. I'm going to move on to some of the work I've been doing with the cradle device. So we actually were very keen on developing something that was practical for a low income setting. My passion for this really came when I worked in South Africa in the late 80s and saw the mortality in preeclampsia that is very prevalent in Africa. And I came back and worked with Michael de Sweet here and learned about blood pressure measurement. Cut a long story short, I was seconded onto the WHO and we came up with a bunch of criteria for a simple low resource blood pressure device. And this is the criteria that the committee I was on stipulated. And I actually set out to make this device with one of the companies. And you can see this is obvious stuff, a cheap device that works well, is robust and is accurate and so on. And the idea was that this device would help dictate who needs to be transported, help the people who do the training, and dictate who needs treatment. Fairly obvious stuff for preeclampsia. And in that trial, we actually confirmed the impact that preeclampsia has on mortality. So here's 1,000 women who died in the Cradle 3 trial, and you can see most of them were obstetric hemorrhage, a reasonable proportion were sepsis, and then another 22% were hypertensive disorders. So the vast majority, like 3/4, were attributed to these three things that require vital signs to identify them. So the blood pressure device that we created was really designed to be accurate and used in a low income setting. And here's an example of one showing a woman who just had an eclamptic fit, where her blood pressure is high on our blood pressure device, but it's incorrect and low on an expensive blood pressure device. This is from South Africa. So actually, it's really important that you use accurate blood pressure devices. I'll give you an example of why this matters. So here is a reading from Sierra Leone, where I was sent this blood pressure reading of 210 over 137, red light. And they said, oh, is this accurate? And I said, well, the machine next to it, which was their expensive ICU machine, said it was 160, 112. And I said, well, actually, we know the cradle device is accurate. You shouldn't ignore this. And actually, they did ignore it because they thought it was a cheap, simple device and their expensive ITU machine would be okay. So the next day I rang them up and I said, well, what happened? And they said, well, actually, this woman went blind 2 hours later. And they then suddenly started to believe the very high readings. So this isn't a lesson that not all sophisticated machines are accurate, and you have to use machines that tell you when things are severe. So this device was originally created and made in China. Here is the prototype. We made sure it was accurate with our team in South Africa. we validated it, and I'm not going to go into too much detail in the interests of time, but we added in a mini USB port so it can be charged by mobile phones anywhere in the world. We checked it in Tanzania, Zimbabwe, and Zambia. We added on the traffic lights so that people would understand when things were incorrect. And we made sure that if the blood pressure was abnormal, it was amber. If it was very high, 160, 110, it was red. And we assessed it for shock index as well. Now, again, in the interests of time, I won't go into this in too much detail, but basically shock index is when you divide the pulse by the systolic blood pressure. And again, to cut a long story short, if your heart is going fast and the blood pressure is dropping, you have a high shock index. So if you're losing blood or if you're septic, that is what happens. We actually evaluated the shock index in various countries around the world, and we showed this, which is that if you have a red light, that's you're tachycardic with low blood pressure, you are much more likely to have a severe event. So much so that a red light meant 1 in 3 women died, 1 in 3 had major surgery, such as hysterectomy, and over 60% were going to ICU. So we thought this might be quite a good tool, and we used it in 1,500 women in South Africa. And again, just to show you that South African data of 1,500 women with preeclampsia showed that 20% were dying, and more than 90% of these deaths were antenatal. And what this taught us was that by delivering babies early, you're going to save most of them. So when you're worried about a baby being delivered early, you have to realize that they've got babies tend to die antenatally, and the way you save them is by delivering them. So there's a tension between prematurity. Now, some of the things we found in that data set was that teenagers were much more likely to get eclampsia. Women of low BMI were much more likely to get eclampsia. And these are things that aren't the same as risk factors for preeclampsia. And I think these are important things to remember when you're looking at risks of eclampsia in your antenatal population, particularly in an African population. Now, I'm just going to move on and show you how this blood pressure device was assessed all over the world, many countries. And interestingly, if the untrained healthcare workers were much more likely to be using it properly a year later when we went back and looked how they were using it. So this is a publication showing how just basic blood pressure technique is used well by untrained people, and that the nurses and doctors actually started to go back into bad habits. We did a trial with this device all over the world, and I just wanted to very briefly share with you some of the results. So here, this was published in Lancet Global recently. We put out nearly 4,000 devices to nearly 3,000 healthcare providers, in 8 countries, around nearly 300 facilities. Basically, the training is available on YouTube, but it looks a bit like this. These are posters. In that trial, we had 2,500 eclamptic fits, we had 1,000 women die, and nearly 700 hysterectomies. And what we found was introducing the device actually resulted in a big reduction in hysterectomies, interestingly, about an 80% reduction. Overall, there was a 10% reduction in mortality during the trial. Unfortunately, we didn't have enough power because of the variability to prove that this was an effect overall. But if you looked at the different countries, there were big effects in some countries, like Sierra Leone and Lusaka and Haiti, and not such big effects in other places. But what was also interesting is when we used the device, we didn't increase the need for transfer and care. We actually reduced the need for transfers for hemorrhage, because I think the right people were being transferred rather than the wrong people. So we liked the idea that we were going to help the healthcare services and actually save money as well. And here is the data from Sierra Leone showing how the mortality steadily dropped after introduction of the device over a 20-month period, over and above what was an expected reduction in mortality. Now, I'm going to finish off by just sharing with you a couple of the trials that we've been working on in Africa. The Phoenix trial, which was done in the UK, showed that if we routinely delivered people from 34 weeks rather than waiting for them to get sick, the babies were better off. The babies were no worse off, and the mothers were significantly better off. And the mothers were also more likely to have a vaginal delivery. So there was a 25% reduction in maternal morbidity, less severe hypertension. And the babies, although they ended up going to special care a bit more often, they had no more morbidity, and actually they had more morbidity in some cases, like hypoglycemia. And here's the data showing they have more vaginal deliveries if you're routinely delivered early from 34 weeks. Obviously, delivering early in low-income countries more significant effects. So one of the trials we're doing at the moment is balancing the advantages of delivering from 34 weeks in terms of removing risk of IUCDs and HIE and abruptions and so on, versus the problems of immaturity. So this trial is ongoing in Lusaka and Dola, and in fact, I just got a text half an hour ago saying they've just recruited someone else in Lusaka this morning. So that work is carrying on in spite of coronavirus, and we're very, very glad for that because of the importance of hypertensive diseases. We're really hoping this will be a lifesaver. In the UK, in 900 women, not a single baby died. Already in Lusaka and Dola, a large proportion of babies are dying at 34 to 37 weeks. So we think by delivering them early, although that's not, it's a challenging thing to do, it might be a lifesaver. And I would just say watch this space for that trial. And here's the data from our previous trial showing that for every baby that dies postnatally, there are 30 babies dying antenatally between 34 and 37 weeks. So by delivering them early, you don't necessarily cause a problem. You may be saving a lot of lives. Because it's International Preeclampsia Day, APECGH is doing a lot of initiatives. If you go onto my Twitter account, which is at the top there, at OBSEvidence, I can direct you to these videos. We've produced some videos in Haiti and in Zimbabwe, which are for women to look at, to try and instill the importance of breaking down the barriers of accepting care and the issues around why it's so important to accept care and be managed appropriately by healthcare physicians, and that's our happy project. APECGH, we are hoping that you will be a leader of this initiative. We were hoping to launch this in Kigali in June, but because of coronavirus, this is stalled somewhat. But this website's going to go live soon, and we hope that you will be able to have a domain in there and lead the way in showing the many other countries we would like to emulate what you've done in a resource that will help. So we're going to put our videos and things on here, and we'll be in contact with you to see how we can work together to lead the way for the rest of the world. I'm going to finish off by this very last editorial that we'd written. So Marcus is on the line, and he helped me with this along with Lucy Chappell, looking at the reasons of how we managed to get to this fantastic situation of only 1 in a million people dying in the UK, all the simple components that lead to that. And I would encourage you to look at this editorial if you just want to try and emulate the simple things, because they are perfectly translatable to the rest of the world. It's not sophisticated reasons how we've achieved this, it's simple reasons, identifying the right woman, delivering them in an appropriate way. Here are the resource facilities on APECGH, and I just want to say thank you to all my team all over the world. Real pleasure to work with them, and I'm happy to take questions.
Thank you very much. Who of the audience can I give the floor to ask a question? Mabel, I see you have a question that you asked in the chat. Would you like to ask it?
Yeah, yes, please.
The floor is yours.
Yeah, I want to find out how long an individual would have to take the aspirin, and then also how available can we have these special machines for monitoring the blood pressures?
Okay, so very good questions. First of all, we would encourage that you start the aspirin early on in pregnancy. So 12 weeks is good because organogenesis is finished and you don't have any concerns at all about influencing how the baby's developing. Ideally, you want to start before 16 weeks. The evidence is that if you do that, you are better off and you're more likely to have a beneficial effect. And you want to take that aspirin at least until 36 weeks. And it's okay to take the low dose, 75 milligrams, right up till delivery. It's not going to influence bleeding. You can still use epidurals, all that sort of thing. So that would be the recommendation for aspirin. The cradle device is available from APECGH UK. We've actually not got any at the moment because of the flurry of interest because of coronavirus. However, we are working hard with the Microlife to make sure that this is something that can be distributed throughout the world. So we've had a big initiative in Sierra Leone, for example, where we've just delivered 3,000 with the DFID program, and it's certainly being used in about 40 different countries around the world. However, we will work with APECGH Ghana to try and get a way of getting this device available to you. So thank you.
Thank you. Isaac Boateng, I see you have a
Thank
question
you.
too. Let me unmute you so you can ask your question.
Okay, thank you very much for the presentation. I'd like to find out, in your presentation, you mentioned that the aspirin, when taken at night, seemed to be working. So I wanted to find out if there's any clinical reason to that.
Yeah, no, it's a curious thing, but it does seem to be real because people have gone back and looked at it, checked it, and done meta-analyses. There is a whole kind of science on chronobiology where they've looked at the effects of taking drugs at different times of the day and with antihypertensive medications as well. And I think because there is a sort of, strokes and things like that seem to be more common at night. So certainly from an antihypertensive point of view, people are keen on making sure you have treatments at various times that may have an impact on your vasculature. Why aspirin it's really difficult to know, but it is definitely a clinical observation. So I can't give a really hard, plausible pathophysiological reason, but because it's such a simple thing, and even if it's not real, you still get the dose for the 24 hours, I think it's something worth doing.
All right, thank you very much.
I see Henry Murama also has a question. Please ask your question.
Yes, thank you, Andrew. I'm interested in finding out this cradle device. How long does it continue to work with the same efficiency over time? Because that will be an interesting factor if it's given out to community health workers for services. At what time intervals do you need to kind of recheck them or recalibrate them? Yeah, thank you.
Isaac, I'm really glad you asked that question because it's such an important one. One of the things we made sure was this was a very robust device. So that was one of the primary conditions, because we know that you buy cheap equipment, it breaks in a few weeks, and this is a common problem around the world. People always go for the cheapest thing and it often doesn't last. So the device has thoroughly been checked. We checked it to a standard of 20,000 inflations to 300 millimeters of mercury, and that is the sort of factory requirement for it to work. Actually, if you get a reading from it, you can rely on it. So you don't really have to check it. The transducer remains reliable. And this idea that you have to kind of check the calibration is not actually a reality. As long as it gives you a reading, you're probably okay. And the calibration trick is not an issue. Obviously, some of them will break, and they will break if they are used a lot. I walked into the hospital in Freetown in Sierra Leone, and one device had been used there for nearly 4 years, and it was the only device, and they were taking nearly 500 readings a day. So that one device had taken over 500,000 readings and was working fine. The problem was they have to charge it every 300 readings. So everyone was waiting for an hour while it got charged. So we're confident that this is quite a robust device, and maybe in a year you might lose 10% if they're being used a lot, but because they're so cheap, I know $20 can be a lot depending on where you are in the world, but that's not a lot to replace a device if it lasts for so many readings.
Thank you. Isaac Ampoma, can I give the floor to you for your question? Just a minute. Yeah, you are.
All right, thank you very much. I realized in your presentation there were some different types of readings. So my question is.
Oh.
Well, we've lost you, Isaac. You've gone to mute. You've gone to mute just before you asked your question.
Yeah, let me.
Just repeat your question, Isaac.
Right. So the fact that we have so many, we have a number of blood pressure machines, and therefore different types of readings, which many are ignorant of what is the right, appropriate measure for controlling high blood pressure. what is your advice? Should we now begin to advocate for a standardized machine? And if it's a standardized machine, what should be the right readings of a blood pressure?
Good. Yeah, no, excellent question again, Isaac. You're absolutely right. If there's any doubt with the equipment you have, if you're using one of these automatic oscillometric machines, what you can do is use your stethoscope and take Korotkoff sounds, and that will help confirm whether the machine is correct or not if you're worried about the reading. Your reading with the Korotkoff measurements is the gold standard, so you can rely on that. There are websites like Stride BP and other sort of British Hypertension Society that actually lists the pregnancy validated devices. And so if you want to buy them, then you need to kind of look and see what is validated. So some companies like Microlife, like Omron, have got a good algorithm for pregnancy, and you need to check it's accurate in pre-eclampsia. So ideally you want to buy one that's correct, and obviously if you want a cheap one, the Microlife device is particularly cheap, and we know it's accurate in pregnancy, the Cradle device. And we don't get shares in it, we don't make money by selling it, it's genuinely there to help the world. If in doubt, use your ears and the Korotkoff sounds to check the device, and that will confirm. You got big differences, then you say, oh, my reading is very different from this machine, I can't rely on it. So if you've got someone who you thinks the reading is or should be higher or suddenly gone lower, just do a normal Korotkoff sound with a stethoscope.
Thank you. There's time for one more question, and I want to give this opportunity to Koiwa to ask hers. Koiwa, are you? Oh, the screen just turned. Oh, I think her internet dropped, so she will be back later. In that case, I would like to thank you, Professor Shennan, for joining us. For everyone, the recording will be available because there was a lot of information, and I can imagine you may also want to pass this on to others to hear about it, including the known challenges we have with reliable blood pressure measurements, and that this can be a solution for this. Unfortunately, we have run out of time a little bit already, so I do want to give the floor to Linda Vonjo to close the session. If you have any questions that have not been answered in this webinar, please list them in the chat, and we'll answer them and circulate the answers through APECGH Ghana's social media channels and email. Linda, the floor is yours. Just a minute. Oh, I'm sorry. See you, because you rejoined again. You couldn't. Yeah, you should be able to unmute yourself now.
Okay. Hello, everyone. It's a beautiful day, and I'm glad we could all join in to commemorate World Preeclampsia Day. First of all, I would like to thank our CEO, Koiwa Ofosuapia, who is the brain behind APECGH Ghana, which is a foundation aimed at increasing awareness about preeclampsia and also saving or reducing maternal mortality through education, through research, and supporting women who have preeclampsia. Would also like to say a huge thank you to all our distinguished speakers who made it to join us today. I know they are very, very, very busy. I know also it's a holiday in the Netherlands, but Professor Kitty and Joyce, of course, you made it to join us today and make our conference a very remarkable one. We thank you for your invaluable time spent with us and the in-depth knowledge on preeclampsia that you've shared with us. Professor Kitty, we say thank you very much for sharing with us your perspective on the global epidemiology of preeclampsia. Professor Srofenyoh, Dr. Srofenyoh of the Greater Accra Regional Hospital, we are also grateful to you for sharing with us the Ghana situation of preeclampsia, which looks a little bit very gloomy, but we are hopeful that as the years roll by, things will change for the better. Dr. Salisu, thank you for sharing with us your knowledge on postpartum preeclampsia, for drawing our attention to a holistic approach in taking care of our pregnant women that we'd have to consider from preconception through to postpartum period. Thank you so very much. Enoch Odame, thank you for sharing with us your new algorithm. Hopefully, as time goes on and this model is tested and validated, it may find its way into our various hospitals for use for predicting preeclampsia. And Salim Wangabi, thank you for drawing our attention to an area which is quite neglected in Ghana, I must say. The mental health of our women has somehow been relegated to the background, but you've drawn our attention to the fact that we need to take a look at this aspect, especially for our women who end up having pre-eclampsia. To our audience, we couldn't have had a beautiful day without you. Thank you for joining us. Thank you for your questions. That has really shaped our discussion. We look forward to seeing you again, hopefully next year. But we are always available online if you have any questions, through our email, through our website. If you have any questions to ask, we are always ready to answer them. And to our team, the APECGH team, thank you for putting all this together. I think that Joyce should put up the list for me. Dr. Buckman, Dr. Dorothea Obri, yes, Koiwa herself, myself, Linda, Dr. Srofenyoh, Joyce, Dr. Vivian Boama, thank you for putting this together. And to our partners, you have been of tremendous support to us throughout organizing this, and even from last year, APECGH Ghana, led by Dr. Joyce Brown, to UNFPA, the Ghana Health Service, the Greater Accra region, and also to APECGH UK, led by Marcus Green, and of course yourself, Prof. Shennan. We are so grateful for sharing so much with us, your rich knowledge on clinical trials and all that you have done on preeclampsia. We look forward to you sharing this cradle device with us soon so that we can also use it here in Ghana. All right, thank you so much to all of you, and hopefully we can see you on or before next year World Preeclampsia Day. Thank you. Joyce, I hand over to you.
Yes, I think you closed the session beautifully. So what I will do is close the meeting, so you'll all be, so the Zoom session will be closed and until sometime in the future.